the minutes.
Okay. Members, so you're all very welcome to today's meeting. Just to remind you about the sensitivity of your microphones during the meeting. Today, the committee will receive 3 briefings. The first should be the Mental Health Champion, Siobhan O'Neill, who will brief on mental health strategy and mental health services. We then have the British Medical Association, who will brief on secondary care doctors, and then we'll have an official briefing from department officials on the Westminster Victims and Prisoner Bill, the Infected Blood Scheme. So just the meeting is now open to the public and will be recorded and broadcast throughout Parliament buildings and online. And just to advise members that you can use your mobile phones as long as they're in airplane mode, and all devices must be muted. And no one can take photographs or record any of the meeting. Are we any apologies?
Chair, just Alan Chambers said he'd be running immediately.
And we've 2 joining online.
Yes.
As well, with Linda, Dylan and Diane are going to join online. I know there's others potentially running late as well. Just under Chairperson's business, there are a couple of things I wanted to just draw your attention to. Next week is Dementia Action Week, which runs the 13th to 19th of May, and on Monday there will be an event in Parliament Building, so just encourage members, if they're available, to attend. There's an event in the morning or mid-afternoon, and then later on there's an opportunity to go on the virtual dementia bus, which I would strongly encourage. It's a very, very good opportunity to kind of see life through the lens of a person with dementia. And all members should have got an email on that from Alzheimer's Society. So just if you want to book on to that. And then it's also Mental Health Awareness Week next week as well. Just one other issue I wanted to raise. We've heard some updates in the media around the numbers for training places for nurses, allied health professionals and social work students, and some concerns that the numbers haven't been increased. In addition to that, last Friday I became aware of an issue around a delay in the universities being getting their confirmed allocation of nursing places, as they were due to put their offers out on Tuesday. And I just wanted to maybe write to the Minister on that, because I feel that we had tried to get a response and we didn't get that. And I think it was late on Tuesday afternoon that the universities were finally informed, which is very concerning, particularly when we're seeing the workforce crisis that our health services facing, particularly around nursing, and the staffing pressures that services are facing. So just to get the committee's agreement that we write to the Minister on that, because we do need to understand why that happened and to ensure that it doesn't happen again. Okay. Yeah. Linda and Diane, you're very welcome if you're online as well. So we have quorum. I'll go to the draft minutes then. If we could refer members to the draft minutes from the last meeting on the 2nd of May, which is at page 6 of your meeting pack. Are members content with the minutes as drafted? Yep. Any matters arising? I have none at this stage. No. Okay, so item number 5 then is the first briefing from the Mental Health Champion. So just where we're getting set up, if I could refer members to the briefing paper at tab 5 of your table papers, which is page 3. And the briefing paper was also emailed to members on Tuesday. So we'll make a wee start on that.
Hi.
Hello.
Yes, you're very welcome. So in attendance today we have Professor Siobhan O'Neill, who's the Mental Health Champion, and Peter Cash, Head of Mental Health Champion Office and Senior Policy and Research Officer. So you're both very welcome. Thank you for your time today. We have about an hour for this part of the session. So I'll invite you to open, and then I'll open up to members for any questions or comments.
Super, thanks. And thanks for the invitation to join you today. So at Health Committee today, I want to highlight my significant concerns about the proposed budget allocations for the mental health services and the mental health strategy. I'm going to discuss the economic case and my key priorities for the strategy. which are crisis services workforce, particularly psychological therapies, strengthening the community and voluntary sector, and integration into the single regional mental health service. And as always, I'm going to talk about the need for smart investment in early intervention and prevention. So we'll start with funding of services and the strategy. The mental health strategy is a coherent action plan designed by experts and people with lived experience to transform mental health services in Northern Ireland. The strategy comes with a funding plan, and the Department of Health have been utilising existing programme budgets to progress key enabling actions and preparatory work. In 23-24, 5.1 million was allocated to the strategy's actions. However, the funding plan stated that 24.38 million was needed. The strategy therefore received just over a fifth of the required investment. The plan states that 42.08 million is needed for 24-25. However, in recent evidence to the Public Accounts Committee, the Department of Health suggested that it might be unable to increase the allocation from that allocated last year, so there would be no increase. There's likely to be no increase this year. This equates to an eighth of the necessary investment for this year of the strategy. The Department of Health have invested a total of 9 million in the strategy, which is costed at 1.2 billion, and we are almost a third of the way through the 10-year period. This is incredibly disappointing. At 7%, the proportion of the health budget allocated to mental health remains lower than that of the other UK regions. The most recent figures indicate that the proportion in England is 11.39%, in Wales it is 13.32%, and in Scotland it's 9.41%. We're all acutely aware of the general pressure within the health budget. However, I'm convinced that if there was willingness and consensus that mental health is a priority across the executive more broadly, there would be an agreement to provide the ring-fence transformation funding for this strategy. Ultimately, we need a 10-year implementation plan with year-on-year actions based on at least 3-year budget security. At the minute, the Department of Health and the Strategic Reform Board, of which I'm part, are tasked with developing annual implementation plans which slowly bring forward preparatory work in the hope that sometime in the near future adequate funding will be available to make the type of progress identified in the strategy to achieve that vision for a mental health service that's set out in that strategy. The changes are happening too slowly, and my fear is that the strategy will become out of date and that it will need to be reviewed and updated. We need to remain focused on delivery, but in the absence of ring-fenced funding, we will again resort to costly, quick-fix solutions rather than the systemic change and the focus on early intervention and prevention, which will reduce the costs over time. The strategy is the very definition of an invest to save model. Poor mental health costs the economy 3.4 billion annually. It's likely to be responsible for over a third of economic inactivity in the under 35s. And it's estimated that for every £8 we spend on physical health, £1 of that is linked to poor mental health. For example, poor mental health can add up to 50% to the cost of diabetes care. The cost of suicide in Northern Ireland in 2022 was 340 million. These costs can be reduced, and this suffering, more importantly, this suffering is preventable. The actions in the mental health strategy will deliver effective treatments and early intervention and prevention activities to reduce that cost. So I'm going to move now to my priorities for 24-25. So one of the most important developments recently was the appointment of the head of the Regional Mental Health Service. So the regional service brings together all of the services into a streamlined system with tiered provision through primary care, the community and voluntary sector, child and adolescent mental health services, adult mental health services, and specialist regional services. It will create equity of access across the region, and the regional outcomes framework will record data on quality of care and outcomes. These developments are important, but they must now be built upon. In their evidence to the Public Accounts Committee, the Department of Health outlined their priorities for this year for the strategy. Despite funding pressures, we should see further progress on workforce, psychological therapies, the regional mental health service and the community and voluntary sector. And these map very nicely onto the priorities that I've been highlighting to stakeholders and are actions that will help reduce waiting times and lead to noticeable change on the ground. But what I'm saying is we need more. Workforce is a very urgent issue that is thwarting progress on developing specific services across the system. We now have a workforce plan for statutory mental health services indicating that we need a 45% uplift in staff. This plan needs to be implemented, obviously, but we also need a workforce plan for the community and voluntary sector. In addition, I recommend that we appoint a chief psychologist or lead psychological officer who will be tasked with overseeing a plan to maximise the mental health workforce. This is an enabling action to expedite the rollout of psychological therapies, including arts and creative therapies and counselling, much of which is delivered in the C&V sector and as such is not included in the current workforce plan. There's no doubt that psychological therapies are effective and cost effective too. We currently spend 12.7 million annually on prescribed antidepressants alone. 1 in 4 women have an antidepressant prescription. The rate is almost 4 in 10 for women aged 45 to 64 years. The current clinical guidance from NICE states that medication should not be a first-line treatment for mild depression unless it is the patient's preference. We recently completed a population survey of experiences of accessing mental health services in Northern Ireland. And at the launch on the 14th of May, we'll publish the proportions who have, I can't give you the numbers at the minute, access services and waiting times and what treatments and support are offered. But they do fall short of what the guidance, it's fair to say that, I think. Funding for training places also needs to follow the appointment of a lead, and whilst this carries significant resource implications, it will be impossible to deliver the type of mental health service that we need without an expansion of training. The vacancy rates in psychology are currently around 30%, and Northern Ireland has the lowest proportion of training places per capita in the UK, with around 250 people applying for 21 places annually. Many of our aspiring psychologists move to the Republic of Ireland or other UK regions to train and obtain employment there. In psychiatry, 16.4% of consultant posts were vacant or unfilled in 2023, and this is more than doubled from 2021, from 7%. The Royal College of Psychiatry report a 24.6% true consultant vacancy rate for Northern Ireland, and that includes both locum and vacant consultant posts, and a true specialty and specialist doctors vacancy rate in Northern Ireland of 28.8%, including locum and vacant SAS posts. So this equates to approximately 88 full-time and 59 part-time consultant psychiatrists. There are also opportunities to expand the workforce by employing staff already available and willing to work in Northern Ireland. Existing courses have produced graduate psychological wellbeing practitioners who can have difficulty finding employment here. There's currently no commissioned child psychotherapy in Northern Ireland. Counsellors who are registered with the NCPS and creative therapists such as arts and music therapists can have difficulty finding employment. New programmes to train specialists such as the clinical associate psychologist for children and young people are being developed. There is a very clear need for the appointment of a leader within this whole system who will be able to work with stakeholders in the universities and colleges to develop the therapies workforce and to build capacity across the system. So that's workforce. I'm going to move to crisis services because that's another priority. The implementation of the Regional Crisis Intervention Service was also highlighted as a priority in the Department of Health's evidence to Public Accounts Committee. In my response to the review of the action plan for Protect Life 2, or suicide prevention strategy, I also reiterated the need for this service to be implemented on the ground. The most prominent gap in my view, and based on engagement with people on the ground, relates to provision for those who are suicidal distress or crisis who do not need treatment in an emergency department or psychiatric hospital. And one element of the model set out in the Regional Crisis Intervention Service is for a service delivered in the community and voluntary sector to meet the needs of that group. This service would be somewhat similar to the DBI Scotland model, where people receive up to 14 days follow-up care after a crisis presentation, starting the very next day. The Regional Crisis Intervention Service model incorporates evidence-based services and would provide that 14-day person-centred intervention programme within 24 hours. This programme would include safety planning, problem solving, wellness and distress management planning, and supported connections to other services if that were necessary. Existing C&V sector services might be able to deliver this, and it would achieve a joined-up system of support and a no wrong door model. DBI Scotland achieves high levels of user satisfaction, reduced distress, significant improvements in ability to meet goals, manage distress, and importantly, the majority of users reported that they received a compassionate response. I appreciate that developments in crisis services are dependent upon workforce and C&V sector integration. However, the evidence shows that every £1 spent on suicide prevention gives a return of over £39. This is clearly cost-effective work, targeting the most vulnerable to suicide, which itself causes a ripple of mental illness and future suicides. It's also important to add that in the aftermath of the murder of Mike and Marjorie Caudry, the PSNI are seeking to more clearly identify the roles and responsibilities of their officers in relation to mental health and in relation to people who are at risk to themselves and others. Developments in this area will be relevant to the response to people in crisis, and it's imperative that we have an effective crisis service in place to ensure the PSNI and mental health services can work together effectively to prevent avoidable death. So, final bit of it, prevention and early intervention. It's estimated that 50% of mental disorders develop before the age of 14 years and 75% develop by the age of 25 years. Therefore, the targeting of treatments and interventions to reduce the burden of mental illness should be allocated to prevention, the identification and treatment of symptoms in children and young people in those groups. Support for parents to promote positive early relationships prevents mental illness across the lifespan and is extremely cost effective. Every £1 spent on universal and indicated wellbeing interventions in schools yields a return of over £5 from the reduction in the risk of depression to those groups. Interventions at this stage of life allow young people to get the most benefit from their education and achieve their career goals. In keeping with this, the Department of Health expenditure allocated to the delivery of the emotional wellbeing, health and wellbeing in schools framework needs to be expanded so that all children have access to effective services from the earliest possible stage. It is also recommended that CAMS, or Child and Adolescent Mental Health Services, receives at least 10% of the overall budget for mental health. At 10%, the proportion appears small. However, people who are living with severe and enduring mental illness, such as psychosis, bipolar disorder, require care that can be costly. And so we must ensure they receive high quality services. But nonetheless, in CAMS in Northern Ireland, there's only 8% of the total planned expenditure for mental health spent in CAMS. So it should be 10% and it's only 8%. And that does limit our capacity for earlier intervention and effective services to prevent severe mental illness. The development of the plan for early intervention and prevention was another very positive outcome from the investment in the mental health strategy over the past 2 years. In order to stem the tide of suffering and service demand, we must now build on this work and implement the key actions from the early intervention and prevention plan. So in closing, I appreciate that the current financial situation that we find ourselves in is extremely difficult. However, it's clear that despite what leaders say about mental health being a priority, decisions have been made not to provide sufficient funding for the mental health strategy and not to provide adequate funding for mental health services. The moral imperative for this work is clear, and we must decide what sort of society we want. Surely the prevention of human suffering needs to be our main goal. And if the moral argument is not convincing, I'm hoping that the cost effectiveness argument might be. So thank you for that.
Thank you, Siobhan. I think that's been very, very informative. So we will have a couple of questions. I know I certainly have, and then I'll open it up. But I suppose there's been so much work done even to get to this point, and it is, as always, disappointing to hear around the funding picture of where things are at and where we need to be, and the huge gaps in that. I suppose, and I have a particular focus around that early intervention, crisis prevention piece, and intervention at crisis stage as well. And you mentioned in your briefing around the engagement with the community voluntary sector and the need for workforce planning around that. One of the big things that we hear all the time is the waiting times for people who are waiting for services, and some are waiting maybe over 2 years in many cases. In my constituency, we have some really, really excellent mental health services in the community voluntary sector. So we have the Mental Health Forum, we have the Well in down Ballymartin direction, and others, but funding is a huge issue. And to give you an example, which you may or may not be aware of, the Mental Health Forum, I think they got which is a relatively small amount of funding of 45,000 over a 2-year period. And within that period, they were able to support 400 people. And at this point in time, they're being told, well, they're not being told of any funding coming forward. Now, we're hearing the waiting times, and you're well, you're well versed in this, Siobhan, around people who are sitting on a waiting list for services. Those 400 people, for example, over the next 2 years, where do they go? Onto another waiting list. And I suppose, and it's probably, I know I'm into a bit of a commentary, but I just wanted to get a wee bit of feedback from you around that. The implications of those community voluntary sector organisations like the Mental Health Forum, like PIP's Open Support in Uri, the Well, and I'm being a bit parochial because I'm very familiar with these groups who don't get the funding they need. What are the implications then? So we're talking here, you said for every £1 spent in suicide prevention, you're getting over £39 in return. That's huge. So yes, the human impact, I think, is where we need to be focused on, but those organisations don't get those smaller pots of funding that can make a huge difference. What do you see as the implication of that moving forward?
The implication of it is that more people will go without services and people will wait longer for services. Yeah. And that's not acceptable because they'll deteriorate. Like all sorts of conditions get worse, but particularly with mental health. And it's soul destroying to be waiting for a service. So some people will go to the private sector, and there's a growing private sector here as well. But yeah, and that's a problem. And when you're talking about young people, they will not be in employment. They will not be getting their education in the way, they will not be benefiting from their education in the way that they could be. So it's really concerning. So the costs are huge for that. But what I would say is that mental health strategy provides a solution to that. The creation of the regional service incorporates the C&V sector. So we now need to do that. And what I would say is that one-off pots of money for the C&V sector, that's not what we should really be doing here. We need to fund this properly. We need to bring the C&V sector into the mental health service, and that's what the plan states it will do, and provide the 3-year sustainable funding streams for those services so that they can continue to grow and do what they do well, rather than having to pivot to fit into a particular box for a pot of money that's made available. So that's the worry. But the other side of it is that a lot of people are receiving services within the 9 weeks, and most people would receive services within 6 months. That's what our survey shows. But it's the people who are not getting the service, and that some people are waiting and never getting effective service. And there are situations where people are treatment resistant and all of that, but the figures don't map onto that. There's a significant level of unmet need out there, and the damage that's done to that individual, but to their whole family and community when they're not functioning the way that they could be and should be, and it affects us economically as well. So that's why I'm trying to make the cost effectiveness argument here too. But we have the plan to change things. So I would be saying let's move a little bit faster on this plan, recognising there are restrictions in terms of the budget too.
Yeah, no, thank you for that. And I suppose then on that, in terms of the plan and the engagement with the department around that, I mean, is there scope to look at those kind of 3-year funding cycles, that it is more sustainable, particularly for the community voluntary sector, who I think complement the statutory services, because everybody brings something different to the table. That's certainly from all of the groups I've met over the years, they all have something unique to bring, and I'm very conscious of, for particularly around mental health, it's not a one size fits all. So people have different needs, and they may not, for example, the statutory provision, it may not meet their needs. So there's other options out there, and I think that's really important in reducing the pressures. Plus, that those people who are sitting on a waiting list for that length of time, and we've heard it from some of the representatives we've had up to brief in over the last number of weeks around those people sitting on waiting lists then have to go and see their GP more often. They maybe are presenting an A&E, and that adds to the broader picture as well. And then, as you have mentioned, the impact on education and economic activity and all of those things which help with people's mental health as well. So
the transgenerational
impact,
the impact on the relationships within the families and the children and the grandchildren and everything, so you're dealing with that. But without a 3-year budget for the Department of Health, they say they're not in a position to fund the C&V sector. Even the ones that are funded, they're not in a position to provide the 3-year funding until that happens. But the model for the regional mental health service includes the community and voluntary sector, and the idea is that they will be equal partners, and that means 3-year funding streams as well. And as I say, there's plenty of roles. They do really, really important work. So it's just about pushing that forward and getting that delivered. Now the plan is there. There does need to be more engagement with the sector. There's been a bit of that work. It needs to continue, and we need a workforce strategy for the C&V sector, because that's where a lot of our counsellors are employed. And we still don't have a handle on how many counsellors are needed. So the mental health strategy workforce plan is statutory services only.
Yeah.
But again, we need that implemented now as well.
Yeah, and I think for particularly around the community voluntary sector, because without the funding certainty, there's a huge potential to lose some of the really good staff that are working there, with the expertise that they bring. So that's another risk, and that's something that we need to address. So I suppose it's about bringing that all together. That's certainly what I think needs to happen. Sorry, the last thing I wanted to ask was just around that engagement then with the MDTs. Because I know from speaking with the Mental Health Forum in Uri, they had a really good working relationship with the MDTs that have been set up there. So have you had any feedback in relation to that? Because I know it's not fully rolled out.
No, I mean, the feedback is mostly very positive around the MDTs. It was a bit about finding, how exactly they would function, and there are some differences, but I think, broadly speaking, they've worked really well. The difficulty is with primary care generally, they're under so much pressure, so getting even to the point where you can get a mental health worker and an MDT can be difficult for people, but that is the model that we need, and we need the therapy hubs set up and functioning in parallel, because the MDTs can't provide, in some cases they can't provide the therapies that are needed. So it's all very well and good getting that triage and getting the appointment with the MDT worker, but it's the follow-up, it's the mental health service behind that needs to work as well. And what you have when you don't have that functioning well, you just have lots of people on antidepressants over a period of time. People who would have maybe preferred to have a psychological therapy or would have benefited more from a psychological therapy, but they're not able to access that.
Yeah, and that's an important conversation. I recently attended the PPR event here, and it was really excellent around the options that should be out there, and that we need to look at into more around, instead of medication as the answer to everything.
Yeah, and for some people it will be, and the guidance is clear that if a patient requests that, even for mild depression, that's that's acceptable. But I guess the reality is that a lot of people would prefer to have a face-to-face psychological therapy, and some of the conditions, particularly trauma-related conditions, they need to be treated with a trauma-related therapy. That means it's a one-to-one psychological therapy, quite a specialist therapy. And people do benefit and get better and really flourish after those therapies are delivered. They really, really work. So it's unacceptable. We have a 30% vacancy rate in psychology, and people can't get access to these recognised treatments for the illnesses that they have.
Yeah, it's about getting that bespoke treatment for the specific needs of the individual. Yeah, no, absolutely. Thank you for that. Ivor Leah.
Yeah, thank you, Chair. Thanks very much, Siobhan, for your presentation. It is really disappointing that, as you said, we're now so far on in terms of since the mental health strategy was published and released, and we haven't got enough of the funds assigned to it to really get it off the ground properly. Do you know what I mean? I know there's been different elements of it that has been delivered, but it's, as you said, the quick wins and the short-term gains aren't going to do anything longer term for dealing with the issues. And what I would be concerned about is, you had mentioned then again the cost of suicide to the economy, then there's the cost of addictions on top of that. So we'll have the mental health strategy, we'll have Protect Life 2, which was being reviewed, and with the substance use strategy. And for me, it's how do we get the best out of all three of those, because all those issues sort of impact on the other: suicide, substance use and mental health. And I think that in terms of the department, they are obviously, all the departments are extremely constrained with their own budgets. But I do think that it's disappointing that the investment in mental health from the department, as the Department of Health, as a responsible department over the health service, that it's still sitting on that 7%. I do think that's really disappointing, and I know that the case has been made with the executive, and all parties have committed their support to mental health. But I think in terms of the health service, number one, we need to see that 7% rising. You know, you can have the collective support from the executive, but the department needs to get that figure up, you know, to give that additional investment from their own department. Now, my question would be around, I know there was the executive subgroup that was set up around mental health, resilience and wellbeing, and I'm not sure if or when that group is due to meet, but those 3 strategies, is that a conversation that you could be having at that executive-wide group, you know, in terms of any way that we could be supporting the Department of Health to try and get some of those really, really important actions over the line across all 3 of those strategies?
So that's a really good point you're making, Earlier. And I met most of the ministers and asked for that group to be reconvened. And that's a really good fora to discuss not only those 3 strategies, but issues affecting mental health across all of the different departments. But yeah, education, justice, you know, there's so much crossover. It's not just about delivering services for people who are unwell or people who have mental illness. This is about the prevention of mental illness as well. So, you know, this work is a cross governmental issue. It's a programme for government issue, really. It needs to be a wellbeing framework for government. So there's that, and I mean, I think that's going to happen, that group will be reconvened. In terms of the 3 strategies, the actions directly align, so the same actions are in the substance strategy as a mental health strategy. So it's not that they're working separately or doing different things. They're all going in the same direction, and I have oversight of all 3 of them. The preventing harm from substance strategy is really important. It includes all that early intervention work that's outside of health. Equally, suicide prevention is about restriction of access to methods, as well as crisis services, as well as education and training. And, you know, so those strategies, whilst they're bits that are outside of health, they are lined up nicely together, and I can see that they will make a difference, but there isn't enough investment in any of them, you know, really, and it would be good to have that working group together. Yeah, no, well, that's good, and you can hopefully let us know if well, I'm sure we'll hear anyway, but if that group's reconvened, and, you know, some of your input into it, so we know then, you know, anything that we can be doing to support you as the Health Committee in terms of the work of that executive-wide group. But then just finally, I wanted to ask, you have mentioned around the unmet need as well, which is massive, and we know I think it's going to come out in the Public Accounts Report around the issue of data collection in terms of mental health and the downfalls there. But the Regional Mental Health Service, Gavin Quinn's obviously new into post then, he's the chair of the board. So there was feedback, I know you attend regularly all of the APG, Siobhan, but the suicide prevention APG, we were getting feedback from the C&V sector that they were feeling that they haven't been as involved as they could or should have been. So we're doing a joint meeting with the mental health and suicide prevention APGs. Gavin Quinn has agreed to come along and basically do a single focus session on that then, about their input hopefully, and the updates around the work that he's involved in. So we'll get the details to you if you're available to come along to that. But I think it's important that we just stay on top of that conversation and engagement, so no one's sort of feeling left behind, you know, right across the system. So everyone's working together to, you know, to try and obviously do as much as we can to keep the C&V involved. And then on the workforce plan, so again, you're right, the C&V sector they weren't part of that plan. It was only statutory services. But just on that, you mentioned the child psychotherapy. I am massively in favour of a commissioned service for child psychotherapy. When you're talking about the early intervention and prevention, this is dealing with the most vulnerable, scarred kids that need that intense support and help, so they don't go on later in life to have mental health problems. And I know that you've been meeting with Deirdre Meehan as well in terms of that. So do you think that, again, with the tight budgets, is there any
chance, you know, I know that you certainly have support of the APGs, and I'm sure of all the political parties, but in terms of trying to get that commission service, there isn't a big cost to it. And is that something that would have your support, trying to get that commission service over the line and trying to get the local training school? Again, it's something that could be done sort of, you know, it's not like you need to design you need a new building, and you need, you know, some of these things can be done cost effective, but it would have a big impact on the kids that need that service.
Absolutely, but this is why I'm saying what we need is a lead to look at all of the psychological therapies, including child psychotherapy. I mean, the idea that we have nothing here is fairly shocking, you know. So that's one huge gap. But we're training psychological wellbeing practitioners. We have clinical associate psychologists. We have people who want to be part of the mental health service here, who can't be part of the service at the moment because of the way vacancies are advertised, because of the structures. Which is why I would actually be saying what we need is a lead to map all of that out, and then direct the commissioning of training places. So psychology, psychiatry, child psychotherapy, I mean, the list goes on. You only have to look at the workforce plan, speech and language, occupational pharmacy have a role, you know. So it's about populating the service with what we have and filling the gaps and maximising what we have. And that's why I think that lead, whatever that looks like, it could be a lead psychological officer, and they have that in the other UK regions. We don't have that here, you know, just to scope out what the workforce would be. And that's something you could do this year and build on that with your commissioned training places next year. The universities are already moving. They're already creating the courses in anticipation that this will happen. So you're pushing an open door there. It's just about doing that engagement and having a person who's responsible for that. So I think that's the next step for me. But shortly after that, we need commissioned training places, and we could be commissioning places already because we know where some of the gaps are really huge. But making use of the workforce that's here is an interesting project that's part of transformation that I think needs to happen, and it will be a cost-effective action. So that's where I would go with it. And one of the things when you were speaking about the regional mental health service, C&V sector, absolutely essential part of that. But most of mental health care is provided in primary care from GPs. So we need to be bringing the GPs and the primary care practices really into this, and looking at how we can help and support primary care to do this work too. And I think that's the piece that's missing. So you have statutory C&V, but also primary care are really, really important. And that's Gavin's task. And I met with him. I mean, he's from Department of Health, Mental Health, so I've known him and he's been involved in this, and I've been having regular meetings there too. So happy to come and help shape that conversation and ask key questions there and get that rolled out more quickly, that single regional service with the specialist services, with the early intervention stuff in people's communities as well.
Yeah. And see, on the chief psychological officer, we can follow up on that, because it was actually my understanding the last mandate that the minister, we have been lobbying for that post, that role, and there was definitely correspondence that had come through saying that they were intending on appointing a chief psychological officer. So
yeah, I mean, my understanding is that it's supported, and there's a piece of work that needs to be done right now that person could come in. It's just such a time, the right time to do this. So yeah, I think that would be a really, really important development. But we need to invest in the workforce straight away. You know, it can't be about them sitting for a couple of years. You know, there needs to be a budget coming behind that for the training places that are needed. And as I say, we have a committed workforce of people out there, and we just need to maximise that.
Okay, Colin?
Thank you, Chair. Thank you, Siobhan, and thank you for your work and the focus that you give to this really incredibly important issue. And I think actually it's important that your academic background is there, because I think it's clear that the only argument that is going to penetrate here is that there's a cost effectiveness, and saving and research is key to being able to put that argument, because I don't know how anybody could make it any clearer the actual need that there is on the ground for people to have service provision and intervention. And if that's not working and that's not seeing us deliver the right services, then we have to think of a different argument, because we've been having this argument for years that there's an underfunding within the sector. And your report, which detailed like lengthy waiting lists and a lack of service provision, and that we're in a state of crisis, and that we've depleted workforce, and we've got inappropriate placements with people going to emergency departments when they should be going to other places. And I'm sure others will agree that housing and mental health are probably two of the top issues, and they're also connected, but that mental health is up there in terms of what we receive in the constituency offices. And there is a mental health strategy, and it's not being funded. And a strategy is a way of measuring the success. There's the success indicators that should be part of a strategy. I'm just wondering, is it unfair to say that at this stage, a third of the way in, the mental health strategy is failing?
No, I think so. We can't say that, basically. It's not fair to say that. There's been a lot of progress in the strategy. The fact that we have the model for the single regional service, we have the model for a regional crisis intervention service, that's a lot of work. Those are intensive pieces of work where you bring together best practice and look at the system we have and design the system that we need. And people with lived experience and people from the C&V sector have been involved in those projects. So the plans that we have, the early intervention and prevention plan, is a really important piece of work as well. We have perinatal mental health services in place that weren't there before. So it's very unfair to say that the strategy is failing. The strategy hasn't been given a chance to fail. You know, we need to invest in the strategy, and it will deliver if we invest in those 35 actions. We're a third of the way through. Now is such an important time because we're looking at an eighth of the funding. Last year it was around half or something like that. So, you know, there is time to catch up. A lot of people are receiving really, really good mental health care and good treatments and good mental health services, and their needs are being met. So that it's important to say that. And I see that, you know, when I go out to the services and look at what staff are doing on the ground, it's really brilliant. And when I look at the progress so far, there's been progress on many of those actions, like the majority of those actions have been progressed, plans have been made, and you need to give it that time, that bedding in time. But now is the time when we need to invest, you know, and if I'm sitting here this time next year and we haven't invested, then we will be having a different conversation about whether the strategy might be failing. But we can't say that at the minute, but that's why I'm urging you to invest in it right now before we lose the momentum and the work that people have put into this. Yeah. So it's really about investing now, Colin.
I think you're putting the best gloss on the situation, and I understand it because time and time again we have various representatives from all different organisations, and nobody wants to say that somebody's not doing a good job because there's fear that then it doesn't follow from that. But we've seen that the budget for the Department of Health is decreasing, and there's no additional funding for mental health. So I don't know if we're saying that we need, if you're going to come back here next year and there's been no additional money, and we're being told that there's no additional money, we really need to take on board what you're saying and make that representation to the Minister, because that's exactly where we're heading. We're heading for failure. I'll say it if you're not going to say it, and I'm happy to say that because we are getting no extra money into that. And the reference there as well that you made, which is so important, about the money that went to the community and voluntary sector, and many of us went to, for example, the Community Foundation, where there was COVID money that went in. There's an entire infrastructure that went in for mental health services, and then the money's been cut. And that's just been cut, and all of those services are now just drifting away with no funding, no guaranteed funding. All of the infrastructure that's there, all the support services, where, you know, an intervention from the department brought people together, gave them hope, gave them services, and then takes it away again. And it just feels like people are being left with no option but to just go and join the back of a very, 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 very long queue. And I just feel like we're letting people down. I really feel like we're just not giving them the services that they need. And I hope that we can get that investment.
Well, I mean, the final decisions have not been made yet, and that's why I'm here today, to make the economic argument for this. So whilst the department are saying it's unlikely that they will have the funding, and it doesn't, you know, as far as I know, this has not been signed off. And, you know, this is a cross-departmental issue, and it's one reason why we need that group back up and running. So I am convinced if there was the willingness to do this, that the money could be found, because the money can be found for other things. So, and there's a cost of not doing this. So I think it's just really important right now to know that we have no assurances, but things could change and decisions could be made to invest more in the strategy. And indeed, the Department of Health have put out bids for funding for other areas if there was extra money available. It's also important to add on to that, there's money from other sources that are coming in to projects that align very nicely with the mental health strategy. So there's peace money, there's shared island money, there's all sorts of money that can be found for different things. So I remain eternally optimistic that we can increase the money that we spend in this strategy this year if there's a willingness. It's still not too late to do that. And that's why I'm making my case to you, because as I see it in terms of health, the grand plan for transformation hasn't really been produced, and the transformation plan for mental health is sitting here. So we need to invest in it now. We need to find that money. We need to go back to the drawing board essentially and look at what we're spending, and make sure that we can put more money into this so that we can provide the best service and get that process of transformation started.
Okay, thank you. Linda is online there.
I can't see Linda. Oh, there she is.
Oh,
I need to put
still
on
on
the
mute.
mic.
Sorry, the host had muted me. I couldn't get unmuted, so sorry about that. Thank you, Chair. I have a couple of questions, if that's okay. Firstly, I suppose I just want to ask Siobhan, in terms of the issues that you're raising with us here today, and I suppose just to firstly say we agree probably with almost everything you're saying, if not everything. But what are the departments saying to you when you raise these issues? Because ultimately the department have been given their budget and they decide what their priorities are. So the minister decides what's being prioritised. And if the minister is not prioritising mental health and the mental health strategy and funding that, then we need to understand why, because we're not being told what the money is actually been spent on, or more importantly, what it's not been spent on and why. So, you know, we can, and I've raised this at a number of meetings now, so it'll not be anything new to people. They're probably sick listening to me. It probably sounds like I'm repeating myself a bit at this stage, and maybe I am, but it's because we still haven't got the answers. We have not seen what the minister's plans are about what he will spend money on, what he's not spending money on, what he would spend money on if he got additional money. So we can't just say we should be calling for additional money. We need to see what the minister's plans are, and we need the minister to respond to why he's not prioritising this mental health strategy, why it sits at 7%. That's 7% of the overall health budget. That's the money that health gets. So it's not increasing within health, within what they get. That's an issue that we need to get to the bottom of. And I think that we really do need to understand or get a better understanding. So if Siobhan has any answers just in relation to that, about what the department are saying to you when you're raising these issues and we don't have money, isn't good enough. I want to know what they're spending, what they have on, what they're not spending it on, and why. Those the other another couple of issues that I just want to raise as well. The issue around women in their 40s, Siobhan, you know, that increase in the numbers being prescribed antidepressants. I mean, this is just my theory, and I'd like to run it by you just to see if I stand to be corrected. I mean, we've been at a number of events where women who are going through the menopause are saying they're being prescribed antidepressants before there's any conversation about menopause, HRT, or other types of therapies. Do you have any view on that, or do you have any understanding of that? I mean, obviously we want the women's health strategy to be implemented, and hopefully that would be dealt as part of that. But I think that, you know, I'd like to get a better understanding of that. I have another question after that, Chair, but if Siobhan wants to come in on those, because I'm conscious that I've said it for a wee bit in that.
Okay, no, that's no problem, Linda. And yes, so in the Evidence to Public Accounts Committee, so they're still working out the budget. So when I asked the question, will there be they don't know. They don't have the answer. They're still working it out. But a Public Accounts Committee last week, and they're doing an inquiry into this, the Permanent Secretary did say that the only person who could make that decision to allocate, to change the direction of spending and put more money into mental health would be the Minister. So speaking to the Minister, I make the case And he gave me no assurances, I have to say, but I got a really good hearing, and he agrees that this is a priority. So I'm still waiting, in a sense, for that response. It's not appropriate for me to look at the overall health budget and analyse that and say whether, you know, the money's been spent in the right way. And I know there are so many other priorities, so I can only assume that they are working at that at the minute. But certainly any support that you can lend as a committee to that process would be really, really useful. I mean, the budgets are significantly constrained, and there's a lot of demands, and we're talking about saving lives across the whole of health really here. So these are very difficult decisions, and the Minister has to make them. And I think we're just a bit early to make the final statements about what will be spent on the mental health strategy this year, which is why it's such an opportune time for me to be here and make this case to yourselves around the economic argument for supporting the mental health strategy. And mental health services, yes, but that strategy for transformation as well, you know, so it's both. It's not just putting more money into service, it's about increasing the capacity and making sure that we are going in the direction of transformation that we need. So the second question was around the menopause. And yes, I mean, this is the stage of life that we're talking about. Many of those women will, of course, have been prescribed antidepressants at an earlier stage and will still be taking those antidepressants. So it's not just new prescriptions that we're talking about there as well. It could be people who are ongoing. And certainly there's some evidence around for teenage girls, when girls hit the age of 15, 16, the rates of mental illness shoot away up. And there's good evidence around the role of misogyny and sexism in terms of those rates there. And I presented that to, I think it was Education Committee or maybe the Public Accounts Committee, but I pull out that data again. But yeah, that's certainly a factor for adolescent girls, and there's an increase there in the pressure of the education system. So that accounts for some of it, the disproportionate numbers of women. Now, in terms of the menopause, yes, anecdotally, there is evidence that women have been prescribed antidepressants whenever they have symptoms of the menopause, particularly around that time when there was a shortage of HRT medications. So I don't know, and I'm not qualified to discuss, the medication shortages or whatever at the minute, but some of that may well be related to the menopausal symptoms. We have other life transitions at that stage as well. Young people leaving home, women becoming carers. I mean, 1 in 4 people here are on a health waiting list, and the carers there would be mostly women. The majority of them would be women. So women in that age group have a lot going on, a lot of stress and pressure, and we know that affects people's mental health. So again, there's all sorts of factors that will feed into those really high numbers, but they are significant, and we would want to look at them as part of a women's health strategy, certainly. And a lot of that prescribing will be appropriate prescribing, and I certainly wouldn't be recommending that anybody stops taking their medication. What I'm saying is that there needs to be psychological therapies available, and that's in fact what the clinical guidelines recommend, that people who meet the criteria for a mental illness, especially the mild, moderate and severe, they should all have access to psychological therapies. They really work.
Yeah, I absolutely agree. Couldn't agree more. I think that we need a good mix of both. Just finally, and Chair, maybe this is something more for ourselves to write to the Minister. Siobhan referenced the killings of the Cadres, and obviously we know there was a review and recommendations came out of that review. And look, I declare an interest as a member of the policing board, and so I see all too often where police are picking up where health services fail, and just to be perfectly blunt about it, it is right and it is the job of the police service to protect life. But when they have nowhere to bring those people who are extremely vulnerable and distressed and very often needing crisis services, that's a problem. And you have police officers dealing with circumstances and situations that they are not trained to deal with, to be just truthful about it. So I'm just thinking, Chair, maybe we should write to the Minister and ask, in terms of the recommendations, what their plans are around the implementation of them. And Siobhan might have some answers around that. It may have been a conversation that you've already had. Siobhan, something I'd certainly be really raising rather in the policing board as well. But ultimately, mental health, first and foremost, should sit within our health service. The PSNI should not be picking up where the health service is failing people realistically. they need somewhere to bring people who are vulnerable. But that's a separate situation to what happened with the Codries. So there are definitely recommendations out of it that have to be action by the police as well.
Oh, absolutely. There's a task and finish group that was set up to implement the recommendations coming out of that inquest, and I sit in that group, and there's representatives from policing and health involved. There's also alignments with other developments that are part of the mental health strategy too. So there's a lot of work ongoing there. I mean, I think the point that needs to be made is that the work that police officers are doing, it needs to be policing. We need to be able to differentiate what the role of a police officer is, and then clarify what police officers will expect from mental health services, because there was a lot of confusion, and that was very well drawn out in the inquest. So this is about clarifying the role of police officers and making sure that people who are vulnerable get access to the right services, to the care that they need, and that is a crisis service. And in many of our trust areas, there's no alternative to an emergency department, and that's not acceptable. That's not the right place for people to be. So it's about getting people to the right service at the time that they need it, and to identify very, very clearly, so officers are very clear about their roles and their responsibilities in relation to those roles as well, and what they might expect from mental health services. But our crisis services at the minute would not be able to step up and do all of the work that police officers are doing there. So, you know, these projects need to be rolled out simultaneously in a very careful way and piloted. And you know, it's really important, and I fully support what police are doing, because the current system, the way it's operating, just isn't working. People aren't getting the care that they need, and it's not an effective use of police officers' time.
No, thank you very much, Chair, and thank you, Siobhan. I think all of those points are fair, and I certainly, just to be clear, the last thing I want to see is the police wouldn't respond, because first and foremost, life is sacred and must be protected. So thank you very much. I'm sorry if I asked more questions than I should have, Chair. Apologise.
And just, I suppose, before I take Danny, and on the back of the comments around, you know, people having to go to A&E when that's not really the place. One of the really shocking issues brought to my attention recently was about approved social workers having to sit in A&Es for sometimes days because of the backlog. And I think that's frightening, particularly when we hear some of the cases that have been alluded to in your briefing and that Linda touched on there, and what can happen when people aren't getting the treatment they need when they need it. So if they're sitting in an A&E with other people who have physical illnesses and all sorts of things, and they're in a crisis and could be there for days, I think it's just horrendous. So that's something I think that it really shocked me, because I wasn't fully aware of it. But you know, that's approved social workers, and then you have police and others in the same position. So Danny, sorry.
Thank you. I would pick up something I pick up as well, and certainly just from my previous experience as a nurse, we see that all the time, and A&E departments are not the right place for somebody who's in crisis, and yet that's generally where they end up. You know, it is A&E departments are very busy, noisy departments anyway, and it certainly would seek to make the person worse almost. You know, it feeds into their situation getting worse, and it's not the right place for the person anyway. You know, being in that environment is harmful probably. So thank you very much. So I absolutely agree with your the crisis services that we do need to see. The treatments that you mentioned, the psychological treatments, thank you for the report, by the way. It's very, very detailed. There's lots of information in there. It was great. The psychological treatments that you mentioned, saying that they're very, very effective and cost effective, just how effective are they? And what can you refer to us on that, on how effective these treatments are when somebody is referred to psychological treatment? How long would they be treated for, and you know, what percentage sort of success rate would you see? The other thing I want to talk about is the children. I wasn't actually aware of that statistic you mentioned before, that 75% of mental health is by the age of 25, is it? Yeah. Which is quite a shocking amount, given that we only invest 8% of the budget into CAMS. So certainly you can see where we can move upstream. and we can do that prevention piece and try and prevent suffering, as you highlighted again and again, and it is about preventing suffering. The economic case you made is very compelling as well, but the prevention of suffering is the most important thing. But certainly I really appreciate the focus that you put on moving upstream and trying to prevent suffering and lifelong suffering. If you can impact children in mental health, you can prevent a lifelong suffering there. So thank you very much. And the last thing I just wanted to ask you just about, in your view, sorry, I'm taking up a lot of questions here. Is the Minister focusing on the right things given his budget limitations? You know, is he directing the resources that he has in the right area?
Okay, so yeah, we'll start with the psychological therapies. Okay, because I forget the other questions. So percentage success rates. There's a lot of evidence around CBT, cognitive behavioural therapy, as a very effective treatment for depression, anxiety, and for trauma-focused cognitive therapies generally. So the success rates depend on the nature of the condition and the treatment that the person gets. So a lot of the evidence is around CBT, but it's because it's been the most studied. There's also good evidence around dialectic behavioural therapy, DBT, for personality disorder, suicide prevention, that sort of thing. There's a lot of evidence around safety planning for suicidal behaviour as a very effective intervention. It doesn't impact so much. There's less evidence on suicidal ideation, the impact on suicidal ideation, and we need more research there. But a lot of the therapies, the kind of the psychotherapies, the different types of counselling wouldn't have been studied in so much detail. So the idea that you could get 6 sessions of CBT and that you would be cured after 6 sessions, that comes from the research on CBT, but they were very clean samples, very less complex cases used in those research studies. So the 6 sessions model came from that, and we now know that especially in Northern Ireland, where we have trauma-related mental health problems, that our mental health conditions can be more complex, so it might take longer. So the evidence is very, very mixed, but most people who get a psychological therapy and get enough sessions should benefit from that. I would be confident enough to say that. And there are a proportion of people who do not benefit, and psychiatrists will tell you there are treatment-resistant patients as well, and even that is a contentious phrase. So it's a very, very mixed bag, but most people will benefit. I would say as an academic, there's evidence that most people would benefit from psychological therapies, certainly for the more common mental disorders, if you like. Now, the SMEs, severe mental illness, bipolar, schizophrenia, psychosis, there's medication would be used alongside psychological therapies there, and they are more complex, and often people live with those disorders and manage them rather than receiving complete recovery or cure, so there's different ways of defining recovery as well. Now, what we have in the mental health strategy is a regional outcomes framework which incorporates all of these measures, and if we could get that rolled out, we will be able to measure the effectiveness of the therapies that we are delivering, and how well people are benefiting and which patients are not benefiting and need to try other things. I would say for antidepressants as well, there's a group who don't benefit, who need to try different antidepressants, and there's an adage in psychiatry that's a third will benefit from the first one that they try, and then another third will benefit after they've tried a couple, and there will be that kind of third who will not benefit from an antidepressant, and they come with side effects as well. So it's the science on this is at a relatively early stage. It's very difficult to define mental illnesses. There's a lot of debate about the classification systems that are used, but there's no doubt that psychological therapies help people with mental illness, and they are recognised treatments by NICE. And that's where our NHS, our health system, we need to be providing the recommended treatments that are recommended by NICE. So that's why we should be delivering psychological therapies to people, because they really do work. Now, moving on to the second question, in terms of the Minister's resourcing of various different... I haven't been told exactly what's going to be spent on the mental health strategy this year. It's a conversation about indications are it will probably be this. There's no evidence or assurance that it's going to be any more than it was last year. But this has not been finalised. It's not been agreed. And I haven't I haven't had sight of the overall health budget, nor would I want to be involved in those decisions because I don't have that expertise. So at the minute, I think we're still waiting on information about what needs to be spent, but it does look very, very grim. I have to say that.
9th.
Yeah.
Is this a date for a 9th? Yeah.
In terms of the
proportion that you were asking for.
The proportion should really be up to 10%, but what I would be asking for is an investment in the strategy so that we have the workforce, because if you have the money without the workforce, and that's really where the problem is, we need to be commissioning training places. So I'm not necessarily, yes, we need more money in mental health services, and the community and voluntary sector would need more money right now to continue doing what they're doing, but we need to be ensuring that that is in alignment with the strategy and what's needed, rather than a one-off pot of money. We had the COVID monies and they were very, very, very welcome. You know, when that came on the back of the pandemic to meet the needs there. We're now in a slightly different situation where we need to be funding anything that is in the direction of travel of the strategy. And workforce is really fundamental to that. So this is about services and strategy means workforce, crisis services, early intervention and prevention too. Okay.
Diane, online there.
And thank you for the presentation. It is really, really very, very valuable. Can I just ask about, you talk about the number of children and young people who have mental health difficulties and how young those children are now presenting at. And it seems to me one of the things that we really need to try to do is to make some effort to join up what is happening in health and education. And many of our schools and our teachers complain that they have children that they know will benefit, but they have no route to getting them help. And are there recommendations that the strategy can make and that you can make in order to try to make those two departments work more closely together in order to alleviate the problem? Because I have a theory around it, which is that the quicker we can intervene when a problem presents itself, the less difficulty for that young person, both in their young life and then later in life.
This is a really, really important point. We can identify at a very, very young age which children are going to develop mental health problems. And there's a whole field of perinatal psychology and psychiatry that looks at infant mental health. So the mental health of babies and their parents and their caregivers and how that interacts and the importance of those early relationships. But certainly in schools you will have the evidence starting to emerge in the behaviours that need to be addressed that will go on and lead to mental health problems or constitute mental health problems. So what we have is the framework for emotional health and wellbeing in schools. It's a joint Department of Health and Department of Education funded framework. So it's not a strategy as such because it's two departments, but there is money that's coming behind that. And in my evidence, what I'm suggesting is that we expand the money that's going into that framework. Now, what that framework is about, it's about a whole school approach to mental health and wellbeing. So there are universal interventions that are helpful for children and young people, and that is training. That's the resilience training children about their stress response, about how to manage that, about how to regulate their emotions. And that's probably as far as it needs to go in terms of universal interventions. But there will be children who will have specific difficulties, and you want to then get them specialist support, and that's also in the framework. And there's some excellent programmes that are being delivered in the schools as part of that framework. So, and then the third part of it, and that's really important, is that's the connection with mental health services, so that schools can refer directly where there's a child who's showing signs of self-harm or an eating disorder or significant mental health issues, and they need urgent help. So it's getting them to the right source of support as well. So both departments funded this. and are continuing to fund it, but it's not been rolled out in all our schools. It's the same problem. It's piloted in particular schools. Some schools are doing multiple things, and other schools are paying for mental health leads in their schools. There's emotional wellbeing teams in schools doing a great job. So many of these will be social workers who are working with the school to develop that whole school approach and to meet the needs of the children and young people that they serve, that school serves. We have there's a programme for looked after children in primary schools, which is excellent again, and that provides care for those children. And it's about educating all the people who are around those children around how to co-regulate, how to manage behaviour, how to spot the signs, to give them confidence to do that, so that they can get on with the job of educating the children that they have, because that's their key role, and that's what they were trained to do. So that it's about managing all of that. And again, and I have a couple of lines in there embedded within this evidence, really calling for an expansion of that, because at the minute we are looking at, and part of that board is, what can we not do here? What do we not deliver in our schools? And that's not good, because that is so cost effective when you do that. And recognising that schools need to work with parents as well. It's never just about providing an intervention to a child. It's about working with parents in the community and the family, so that you have that wraparound service for that child, and that you have the relationships right in all of those settings, so that the child can get the best from the education that we're investing in.
Okay, Diane, thank you. I'm just very conscious of time, because our next briefing is due to start. It should have started. So I've got Alan Robinson and Nuala then.
Thanks, Chair. Thanks, Siobhan, for the
Hi, Alan.
briefing today.
Thank you.
I thought it was invaluable. I thought it was scripted in a way that was very understandable, and unlike some of the other documents that we've had presented to us, where it was very wordy, and this, I think, just hit the bullseye. And I appreciate you were injected positivity on the back of Colin's comments earlier there. Certainly my reading of the report, for me it was a sad indictment upon the Department of Health. No commissioned child psychotherapy services in Northern Ireland. I thought that was startling. Currently spending 12.7 million annually on prescribed antidepressants. It's a shocking figure. And also the line that any preparatory work in the hope that sometime in the near future. I mean, that's a sorry state of affairs, that we're now living, people who are currently suffering from mental health, who could benefit from services being rolled out, are now living in hope, just literally in hope. And I suppose it's a reflection upon many of the presentations that we've had to date within the Department of Health. Just on the back of that figure of 12.7 million, if you do not get what you are hoping for, what is, or maybe that is a silly question, what is the direction of travel for those people who are languishing on antidepressants? Do you expect to see many more on antidepressants without receiving the services that could get them off antidepressants? And I'm really pleased that Danny raised the question earlier here about services that can benefit, intervention services. I was one back 30 years ago who did benefit on the back of trauma-based CBT, and from going from someone who was in crisis with no job or losing a job to then receiving that intervention and going on to be a civil servant, to being a local elected councillor, to being mayor of my town, to now being an MLA. There is proof there that those services do help and can help. Not everyone, but I am proof that they do help.
Yeah, that's very powerful. I mean, that's the reality of it. Particularly when you're talking about children and young people, getting them early, you can turn things around. You really can make a huge difference there. The therapies work. I don't want to give the impression, though, that there's no mental health services, because there are. And, when we launch our stats on Tuesday, it'll be clear that a lot of people are receiving very high quality care within the recommended time period. But Many people aren't. Many people choose antidepressants, but a lot of people feel that they have no other option, or their situations are such that no amount of counselling will change things. And there's that as well, that the talking therapies won't benefit people like me because of my situation, so people feel hopeless in that moment. So we need to expand psychological therapies. We really do. They change people's lives, often within a very short period of time. Many people need more than the 6 sessions, that there be no doubt about that. But often you see a difference in a few sessions, and particularly when we're talking about children and families and just getting parents and everybody to work together, you can change a child's situation in a way that really is life-changing. And it's a really sensible investment. So that's where we are. But I would urge people to continue to ask for the help that they need, and continue, if somebody's suffering and they're listening to this, ask for the help, because many people are able to get the right service very relatively quickly within those 9 weeks. So there's always that. There's always the chance that this will work. And we have Lifeline, who are there 24 hours a day, 7 days a week. And they provide counselling as well, suicide prevention counselling. And there are services, and many services who don't have long waiting lists. But, it just varies across the trusts, and it depends where you go to. And people have to do too much work to get a service that they should be getting as a matter of course, because they have an illness that's treatable. That's the problem.
That's why I could very much relate to that line where you said that the strategy is the very definition of invest to save, given my own perspective.
Yeah.
And how I could have been a statistic, economic inactivity. I could relate to that very much. So I really thank you for this report, and I hope on the back of it that
Thank you for sharing that.
pose some very pertinent questions to the department.
Yeah, thank you, Alan. Nuala?
Thank you, Siobhan, for your presentation. And I agree with a lot of what has been said. I think I just would like to say that antidepressants is a group of, I guess, a kind of group of medicines that are used to treat people, and that it should not be seen as a stigma or something that negative, in which if someone is prescribed them, that it is important and subjective to that individual person. And I just think it is important to say that. I wanted to ask a number of questions, and I'll just go through these now. Before we have this regional model actually up and running and properly invested, what kind of cooperation are we seeing between the trusts, and has that cooperation improved given we have had this strategy actually published? Because we obviously will have anecdotal evidence from our constituents right across Northern Ireland, so it'll be interesting to hear your perspective on that as well. I also wanted to ask, have you had any engagement with the department with regard to the mother and baby unit, and in terms of how that what the engagement has been in how that will not only be staff but actually the progress for those women who are suffering from postpartum psychosis, for example, regarding that issue, and then also with young people and the services that are there and offered to young people. We recently had a visit to the Children's A&E, in which we learnt of the number of young people that are presenting who have self-harm but also attempted suicide, which just some alarming stories that we're seeing, and I just wanted to ask if you have had any engagement with regards to any commissioning of children's services within the Children's Emergency Department, to make sure that they have all the tools that they need. So we have, again, everything that we hear from our constituents, it's obviously anecdotal, but it's actually real life examples.
Okay, super. Just to say on the antidepressants, they are a recognised treatment. They also really work. People get enormous benefit from antidepressants to get them to a point where they can change things themselves and support their own mental health and well-being and get them through very, very difficult times. So they're recognised treatment. The other thing about that antidepressant category is that that's only one fraction of the mental health medications that are prescribed. It's one type of medication, so when we give those figures, that's for one type of medication. People with mental health difficulties are more likely to be prescribed pain medications and analgesics as well. So we did an analysis of that, and indeed pain medications are overrepresented in the population who die by suicide. So that's a fraction of the mental health medications that are prescribed, but it's an interesting example because depression is one of the most common mental illnesses that we have here. And there's anti-anxiety medications that people will take as well, in addition to antidepressants, an alternative to antidepressants. So that's not the full scale of mental health prescribing, really. So that needs to be said as well. Right, so in terms of cooperation between the trusts, I can't comment in terms of what it was like before I came into this role, because I was working in a university looking at data and suicide and mental health projects and stuff. But I can say that I've seen very good evidence of cooperation in terms of people who are in crisis, who need a bed. They manage beds across the trust, but there are not enough beds overall. They do work together. I have met with all the directors together of the trusts, and we've had very important conversations. So my view of that is that there is a lot of cooperation, but the reality is that mental health is subsumed within those trusts' budgets, and we need a ring-fence budget for the delivery of mental health services, because the trusts deliver all sorts of other services as well. So that is something that will be a challenge in terms of the regional mental health service and how that's delivered. So in terms of engagement around the mother and baby unit, yes, this is something that obviously I've been calling for. It's the final piece of the puzzle in terms of perinatal mental health services. A location has been identified for that unit, and that piece of work needed to be undertaken. So, the first few years of the strategy have certainly not been wasted. And that again is a piece of work that was done there. I think funding now is the issue, but what I will do is I'll go back and ask for an updated position on that. But it's certainly on my radar, and this is needed. In the meantime, a lot of the trusts have dedicated facilities for women with babies. So it's not to say that there's nothing out there. But we need the mother and baby unit to provide that focal point and to provide that the residential care for people who need that with their babies, and that early relationship is so important. So we do need that, and that's really, really important, and we need to keep asking for that, and not to be saying that because we have the perinatal mental health teams in each of the trusts that's it. We've got to go and complete that action, and it's only 1/4 of an action in the strategy. That the action that is in is only part of it. Is perinatal. There's early intervention for psychosis. There's personality disorders and eating disorders, if I recall, there as well. So we have a long way to go really in terms of that. Children's services and emergency departments. This is not something that is in the current regional crisis intervention service model. It's an adult service. There is another action that is around that children's crisis and children's crisis services generally. And of course, the paediatricians have been saying to me that they are finding it completely inadequate whenever they're looking for mental health support for young people that come having self-harmed or who have physical injury, but it's very, very evident that there's a mental health need there, that they have difficulty getting the emergency support psychiatry services for those young people. So that is something that's needed, and there hasn't been much progress on that as far as I'm aware, but it's an action within the strategy, and we need to keep moving there, because those children and young people, they are so vulnerable, and we need to be meeting their needs. That's a huge cost further down the line, not to mention just the idea of children suffering, so that needs to be sorted out too. One of the many things. Yeah.
Thank you, Siobhan. I think we probably could ask a huge amount of questions around this. It's such a broad area, but so important, and that early intervention is critical to it all. But I think there's stuff we maybe will want to pick up with the department, particularly around the funding element of it. And I mean, certainly from our perspective, I know I'm getting very frustrated because we have not seen any plans in terms of where our funding is going to be directed. And we've raised this repeatedly, I think, at this stage. A budget has gone through the executive in the last number of weeks, and we are still not seeing where that's going, or what the plan is for that, or what the plan is if there's additional money. And we need to see that, and you've outlined today just as well how important it is that we see that as a committee, so we can scrutinise that in advance of it going through the Assembly. So thank you both for your time. It's been certainly very, very useful for us, and hopefully we can see some progress in this, and we'll continue to work on that time ahead. So thank you both.
Thank you.
Sure.
Thank you.
Okay, members, thank you all for your questions there. I think if there's anything coming out of that we want to raise with the department or anything we can, Colin?
Yeah, I mean, Chair, I think we need to ask the question about the funding. I wouldn't share any of the enthusiasm that Siobhan has that there's going to be additional money for mental health. I certainly don't think it's going to be anywhere. It's not even going to scratch the surface of that strategy. And I think we should just ask the question. I think we should simply write and say, will there be more money available next year for mental health, and how much will it be? And if we don't get an answer to that, then I think we start to narrow down what the questions are. But you know, we've heard there of probably about 40 different initiatives that are ongoing, and nearly each and every one was, and if we had more money we could do this, and if we had the right money we could do that. The bottom line is we don't have the right money, and we don't have more money unless somebody's got a secret plan for mental health somewhere that we haven't seen, and therefore it's just going to continue to get worse. So I think we do, and it goes back, I think, to the points that Linda made last week and has been making regularly. We just need to know what money is being spent where in the department, so that we can then maybe take the step back and say, well, we understand what your spending scheme is because you've got to prioritise X, Y and Z, but we don't know, and I think that makes our role scrutinising a department very, very difficult.
Yeah, no, absolutely. There's a couple of things I would like to say. Firstly, around the community involvement sector funding, I'm very conscious that a lot of those organisations' funding is now finished, and they don't know if they're getting any more. So if we can get information from the department on that, because they're critical services. Secondly, and Siobhan alluded to it in one of her answers, is the disparities across trusts in service provision. So if we can get some information on that, what's our, you know, just because you live in a certain area shouldn't mean you've access to better services or more services, or shorter waiting lists. So I think we need to hear some around that, and what plans there is to try and tackle it. Are they working together, or what, if any, work is happening on those issues? So that's it, Nuala.
Yeah, just Colin said next year, but did you mean this year? Yeah, no, just because
this year
to get it right, because they'll just come back and say we don't know anything.
Absolutely.
And that's the thing. I mean, I don't know about others, but I can't listen to this anymore of where we're saying we've no money, so we can't do anything. We need to know what we're doing.
Yep.
So
And just on Colin's point, sorry, Chair, I would agree. Keep the main, like the first question, keep it as concise as possible, and asking the direct question: does the Minister intend to increase the amount of spend towards mental health services? It's currently on 7%. Is he going to increase it? By how much? What does that include? No, try and be as specific as possible to try and see if there is going to be additional investment or not, I think.
absolutely. Linda, were you looking in there?
Yeah, just quickly on that point around the recommendations from the Quadri inquest. I know Siobhan gave us some kind of an outline, but I would like to know specifically from the department what the relevant recommendations are for them, and what is happening in terms. I just want the detail on it, to be honest. I want to be able to understand it, particularly given that I am on the policing board, and I want to be able to focus on it from both ends, because in my view, I've dealt with some constituency issues that mean that nothing has changed as it sits at the minute. And I'm not saying they're not doing work, but nothing has changed in terms of that would prevent this from happening today. And that's a wee bit frightening. But that's not to say they're not doing anything. So I just want to get an understanding of that, of what exactly the relevant recommendations are, and what's happening around them.
Okay, no problem, Linda. Thank you. Look, members, I'm conscious we're about 25 minutes over time here, and we've got 2 more briefings. So at that we'll go to item number 6, which is the briefing from the British Medical Association, the secondary care doctors. So you're all very welcome, and apologies for the delay. So members, just at your papers, in your table papers, page 8, you will see the briefing paper from the BMA, and a response from the Minister in relation to junior doctors' pay is at tab 6, which is page 20 your pack. So you're all very welcome, and thank you for your time today. Today we have Dr. David Farron, the Consultants Committee Chairperson for the BMA, Dr. Leanne Davidson, the SAS Committee Chairperson for the BMA, and Dr. Fiona Griffin, the Junior Doctor Committee Chairperson. So you're all very welcome. Thank you. We have roughly about an hour for this, so we have a briefing paper, so just if you want to touch on that, and then I'll open up for questions, and I will be a wee bit more stricter members this time around, so thank you. So go on ahead.
Thank you, Chair. Thank you, members of the Health Committee. Thanks for having us here today. My name is Dr. Fiona Griffin, and I'm the Chair of the Junior Doctors Committee in Northern Ireland. I represent about 2,000 junior doctors with experience levels ranging from 1 year to about 15 years. I myself have been a doctor for 8 years, and I'm currently working as a GP trainee. As you'll all be aware, all of us before you today represent branches of practice that are in formal dispute with the government regarding pay. Combined, we represent every doctor working in every hospital in the north, as well as all of the GP trainees. Our ask is for full pay restoration. Since 2008, our pay has been eroded by 30.7% when compared with RPI inflation. This is the result of years of below inflation pay awards, no pay awards, or pay awards paid much later than promised, such as this year. Over the past weeks and months, you will all have been briefed on the current state of the health service by numerous parties, and each of them said the same thing, that we are in crisis, that the service is at breaking point. We're going to tell you no different today. Some months ago, I spoke with a colleague who advised that she was leaving for Australia after her second year on the job, alongside 26 others who all graduated from the same class in Queen's, all of whom had been awarded jobs with generous remuneration packages. Each and every day I speak to doctors who are planning their escape from the NHS. And when I ask, why is that? Why is everyone planning to leave? Well, we have the poorest working conditions for doctors than any other place in the UK. Training places are going unfilled. Last year, 121 GP training places were available and 22 sat empty. 10% of Foundation Year 1 doctors, that is now those who are starting their first year of work after completing medical school, 10% of those doctors resigned their offer of a job in Northern Ireland before their first day, and that left significant gaps in rotas that had already been created. When jobs go unfilled or when doctors leave, there is an increase in the burden of work that falls to those of us that remain. Doctors who stay are expected to pick up the slack from empty lines on rotas. They're expected to work as hard as 2 or 3 doctors, to work longer and to cover extra shifts, and then they end up burnt out and emotionally drained. Training is also then impacted, so doctors on short rotas are less likely to get to elective operating theatres or to procedure lists or to outpatient clinics, and these are the opportunities that are required to develop as a doctor and to achieve the level of skill and competence that is required for independent practice. With all this in mind, and with the lowest salaries of any doctor in the UK, how can we expect Northern Ireland to attract and retain the best and brightest? In 2022, the BMA surveyed medical students, and only 7% said that they plan to stay and work in the HSC&I when they graduate. If I was tasked with workforce planning, I would be very, very troubled by that figure. I encourage you all to reflect on that and to understand that continuing with current pay and conditions is really not an option. We need drastic change, and we need it very quickly. I'll pass you over to Dr. Davidson.
Thank you, and thank you all for having us here. My name's Leanne Davison. I'm an Associate Specialist Doctor in the Regional Intensive Care Unit in the Royal Victoria here in Belfast. And I'm also the Chair, obviously, of the SAS Committee here in Northern Ireland, representing the 600 plus SAS doctors that work across secondary care in Northern Ireland. SAS, though I think we're very special, doesn't stand for special forces in any way. We've no military connection. It stands for specialists, associate specialists and specialty doctors who work in permanent posts in secondary care, and they're doctors who have chosen not to follow formal training pathways towards consultants or GP, but who nevertheless play a key role, which is often overlooked in the health service. SAS vacancies, the ones that are documented, are rising, and that not least because of the benefits that we had hoped to see from the new contracts in 2021 haven't materialised on the ground, and SAS doctors are feeling hugely demoralised and sidelined. There is a wealth of experience and expertise in this cohort that is not being utilised to its full extent and potential, and workforce planning has traditionally not included this group of doctors, which I feel is not fit for purpose without including us in that discussion. The three of us here today will obviously be describing the issues specific to each branch practice, but as you'll hear, we're all facing the same issues with more and more work, with less and less resources, and declining pay. And specifically, as Fiona mentioned, in Northern Ireland, the DDRB pay recommendations are consistently paid here months after the rest of the UK. And the award for 23-24 we still haven't got, despite the Department of Health in February promising that it would be paid immediately. We're hoping that it might be in June of this year. For the first time, as you've heard, in Northern Ireland, all three branches of practice in secondary care are in formal dispute over pay. And that is really because the NHS has traditionally relied on the goodwill of its staff. It's never been staffed properly. I'd go as far as to say it's a Ponzi scheme where you're kind of, just do the work, suck it up and you'll get there. But that well of goodwill due to those sort of hours of staying behind to make sure that patients are safe at the expense of our own skipping lunch, toilet breaks, and missing out on our own family lives, combined with the last 4 years of the pandemic, has just meant that we have nothing left to give above and beyond. And doctors who would have happily worked well into their 60s and beyond are now looking to retire in their 50s. And younger doctors are either leaving the UK to work elsewhere or leaving medicine altogether for different careers. And hospitals without the staff are just buildings. And to retain and recruit any staff, but obviously we're speaking for doctors, they have to feel valued, and it's only by addressing pay that we feel we'll be able to address then the underlying issues that are within the health service. So I'll pass over to David.
Thanks. I'm David Farron. I've been a doctor for 22 years and I'm a consultant working on the Northern Trust for 11 years, 360 days, give or take a few hours. These are undoubtedly the worst working conditions I've seen in the health service in Northern Ireland in those 22 years. We consistently have doctors working longer hours for less remuneration, expected to do more with less. We've had years of efficiency and the health service is cut to the bone. It cannot go any further. As my colleagues have said, we've faced increasing workloads, we've increasing vacancies. The data from the Department of Health shows that vacancies are climbing among consultants. The numbers don't quite tally with the numbers that we see on the ground when the BMA did a Freedom of Information Act request. They estimate consultant vacancies in Northern Ireland are around 20%. Now, some of those are filled by locum doctors, but a lot of those aren't. And I work in a department myself where we're carrying vacancies and have to depend on locums to provide a service. As a result, we have increasing burnout, we have waiting lists that are frankly a national shame, and we have doctors who are sharing a land border with an area where your health service is more resourced and they can earn 2 to 3 times their salary. And understandably, they're leaving, and they're not announcing that they're leaving, they're just going. They're just quietly quitting and disappearing off the face of the earth. Pay is our central issue of concern. As my colleagues have mentioned, our pay uplifts have not kept track with inflation for some 15 years. In Northern Ireland, we were specifically criticised by our pay review body because we consistently pay these late. And as you've heard, we're expecting the 23-24 pay uplift, which striking consultants in England were paid in October. We're expecting it in June. We have yet to be told which year that June will be, but we assume it's this one. It is a tipping point in Northern Ireland, particularly for consultants, because we also have had about 15 years where the Clinical Excellence Award scheme, designed to reward consultants for going above and beyond their standard care, have been absent. So we haven't been paid those compared to other doctors in England. And in Scotland and Wales, they have slightly different schemes, but they're all roughly the same point. We have nothing. We've been working with the department to get a Clinical Excellence Award scheme put back in place in Northern Ireland. That was put out to public consultation back in December. It closed in February. It's yet to be published. The first step in addressing our staffing levels is to address the pay erosion that we've seen. We cannot expect people to come to Northern Ireland and stay here if they can earn better money for the same job somewhere else, delivering the same or better standard of patient care to the population there. Our waiting lists, and I say unreasonably long times for treatment, are a cause for distress for both doctors and patients. I chat to surgeons who are concerned that they are missing cancer treatments, they're missing patients because the waiting lists are sitting there, and by the time they're going to operate on these patients, it's too late to actually have a curative or a good outcome from that surgery. More frightening, I think, is the fact that the medical students are seeing this and are not seeing Northern Ireland as a good place to stay and a good place to practice medicine. Again, that is a national shame, I think. To sum up from the three of us, we represent every hospital doctor that's currently employed in Northern Ireland, as well as GP trainees. We have taken time away from our clinical responsibilities to give evidence today, because without your support to restore pay to a level that adequately values the skills and expertise that every grade of doctor provides in Northern Ireland, we simply will not have a health service for us, yourselves and our families. Thank you.
Thank you all. That was very good, and I mean the briefing was really informative too. So there's a couple of things I want to pick up on from that, and I think Leanne, your point around without the workforce we'll only have empty buildings. I think that is it's such a very powerful point, because that's something we have been saying right across every sector in the health service, and workforce is the underlying issue that we're finding with every crisis that we're talking about. So that's a very, very important point that we need to really emphasise coming out of this. I suppose firstly, I mean I've met with some of you before, and I'm very aware of the issue, and we were quite hopeful that there may be some progress when negotiations started following the last strike action. So it's just to kind of get a sense of, I know you've said in your briefing that some of the non-pay issues, there has been some positive soundings around that, but and I know that you're very aware that the overall where we want to be, so the 30% uplift that is required, you're realistic in understanding that that's not going to be achievable in the short term, okay? But essentially we'd like to work towards that. Without breaching, I suppose, the confidentiality of the discussions you've had, where are we getting to with the department and with the Minister on that, in terms of moving anything forward around the pay issue?
So, thanks for your question, Chair. We are getting nowhere, to be quite frank. As you read in the briefing, there had been some movement on non-pay asks. Just to take it back a bit, we've had 2 meetings with Department of Health officials. When that was after our first round of strike action, the 6th of March. The first meeting we went to, we were told that any additionality would have to come from a contract renegotiation. We accepted that. We said, okay, this is something we would have to think about. We did have to think about the timelines, however, in which the Department of Health wanted to achieve this contract renegotiation. We'd also discussed at that meeting about the trust and how there hadn't really been much trust between certainly my branch of practice and the Department of Health, given years of experience. We talked about possibly working on some non-pay asks in the meantime between our meetings as a method of proving that the Department of Health that we could trust them. So they did start to make some movement on that. When we went back for our second meeting, they'd give us an update on where they had got to with some of these non-pay asks. In the meantime, since some of those, what we had talked about at that meeting actually turned out to be a little bit less favourable to us as to what were discussed in the room. Initially, we were told 10%, all the trust chief execs had agreed that 10% of doctors' working time would be for self-development time, that is portfolio audit, research, that kind of work. That then transpired in a document I received a few days ago, actually to be 1 afternoon a month, which is not the same as 10% of a doctor's working hours. So just some discrepancies in what we had discussed in the room and what we have come to understand was the intention thereafter. In addition to the discussions that we had, we talked about working times and safety and things like that. Those things had been agreed to. We're yet to see them come into practice. We talked about August as a start date. We'll see soon, hopefully, if any of that is actually, if we're making progress on that. With regard to the contract then, so at the second meeting, we were able to agree that the time frame that the department had initially suggested would not be reasonable, nor would be appropriate to try and negotiate a full contract in that amount of time. It was a period of 3 or 4 months, something very short. And looking at our colleagues, I've also never negotiated a contract, so but I know that it takes a long time. And our colleagues in Wales negotiated a contract with their government. It took about 2 years. During that time, we suggested that if we were able to agree on an above DDRB, that is our pay award body, if we were to be able to agree on a percentage uplift above that, we would be happy to engage in that process of contract reform, because of course we want to bring our members with us. Our ask is for full pay restoration, and if we're not working towards pay restoration, no matter how soon we achieve a contract, our members won't vote for it unless it goes far enough with regard pay. So we'd ask that question: can we negotiate an above DDRB uplift? And the officials went to the minister, and the minister said no. So when someone says no, it's no longer a negotiation. That is the end of the discussion. And that no came before the announcement of the budget. It was just an outright no. We've heard nothing since, and I know that the minister has said that his door is open for negotiation, but when a party says no, to us, that's not a negotiation.
Okay, that's fair enough, and I think it's quite disappointing to hear that, particularly if that happened before a budget was allocated, discussed at the executive, and I suppose one of my other questions was going to be: do you believe that the department have been negotiating in good faith? Probably can answer that for you, given what you've said.
I believe that there are members of the Department of Health that are, of course, going into this in good faith. However, I think that the people who we have been speaking to have been exceptionally limited in their ability to make any progress. Mm-hmm. For example, when we're talking about negotiating a contract, there was no figure put forward for what envelope that would look like. So we can't undertake a negotiation about a contract if you don't know how much it's going to cost or how much money there is to play and to allocate. So I think they were very limited, but I can't really speak.
No, yes, no, I understand that, and I suppose then, and it's similar to what we've talked about in the last briefing. We all understand the financial constraints of what we're operating in, but I think that for the purpose of a negotiation like this, it may have been useful for the minister officials to maybe put forward of, if I get X amount, this is what I can offer. Is this something you would be able to consider, accept, and do it in that way? So, because we know that it's a very fluid matter in terms of the budget, and that's an ongoing process. Do you think that would have helped rather than getting a flat no?
Absolutely, yes.
Yeah.
So we're very realistic about the budget. We understand, we've continuously heard briefings as well as you have about how little money there is in the pot. We are aware of the situation, and we are reasonable people. Yeah. We're not asking for immediate uplift of all of that 30% that has been eroded. We would be very happy to agree, like Scotland did, to work on a pay uplift year on year and to negotiate year on year for something just a little bit extra to make up for that shortfall. We're not wanting this all in once. We know that's not appropriate.
No, that's fair enough. So just very quickly to move on then to the impacts, and you've talked extensively around the people you'd said it, David, around the quietly quitting, and we've heard that from the GPs as well when we had the primary care doctors in, and also one of the figures that I noticed in your briefing was around the 2022 survey around medical students, and only 7% of those students indicated that they were planning to stay here, so training here, but so 93% were intending to leave. To me, and I know have you seen that playing out over the last couple of years, and has that got worse from 2022? And it is related to the pay issue, very clearly.
From a consultant's perspective, we haven't seen the impact to the medical students. But when I spoke to consultants, I went out to meet members across hospitals in Northern Ireland in the last week or so, because obviously we have opened our ballot as of Tuesday of this week for industrial action in the future. The big message I got from consultants was when they were speaking to their registrars, their very senior junior doctors, who would be consultants colleagues in the future. And you always have that conversation about 6 months before they're due to finish to say, well, where are you thinking of working? If we have a job coming up, would you be interested in applying it? Every one of them said that they were saying, not interested. We've got an interview in Dundalk, we have an interview in Dublin, we have an interview in Cork. They're moving south to the Sláintecare contract for better paying conditions and the ability to practice their craft and deliver better healthcare in a system that resources and values them. That was shocking.
Yeah, and I suppose then the impact on that on safe staffing and patient safety, I think, is huge, and that would be a real concern for us as a committee as well. So, I had made a wee note when you were talking about even just some of the situations because of waiting lists, and I think it was yourself, David, said about how surgeons are then going to carry out surgery on a patient and when they realise it's too late. And some of your colleagues in primary care allude to moral injury, and I think that's something that we need to be very conscious of as well, because it's pay is an issue, yes, absolutely, and that would certainly help to resolve a lot of this, but the impact of not resolving the pay issue is much broader than vacancies, but it's that broader issue of affecting the current workforce, our patients, and all of that as well. So just to make that point as well, I'm going to open up to other members. I have Nuala.
Thank you, Chair, and thank you very much for your presentation today. And I do acknowledge that there are 4 days coming up, the end of May and the start of June, for junior doctors. And I mean, I wouldn't want to say I know what the outcome will be, but we probably know what the outcome will be of the consultants' ballot, which has just opened. I just wanted to say I had a recent hospital visit. It's Children's A&E. My son was looked after by junior doctors and by one consultant from the moment he entered A&E until the moment he was discharged from hospital, and the care that was provided was excellent. And unfortunately, you know, one instance, one of the junior doctors in particular, it was 7 p.m. and they hadn't yet eaten that day. You know, that's, you know, I hadn't, because I was rushing my child to hospital. But when someone who's actually looking after your loved ones hasn't, it's not the way to be, and it shouldn't be like that. So I just wanted to acknowledge just all of the work that health workers do, and I see it from first-hand experience. I want to just go back, if you can, to the discussions around the junior doctor pay, and in particular, we have asked questions as a committee, and I've also asked assembly questions, as all of us have, to the Minister, and he has outlined most recently, well, it's dated tomorrow, but we got it today, I got it today, is that his disappointment at the budget, and I understand and respect what you said about the budget, means that there will be, you know, can be no additionality, but that it's due to the budget. But you've told me that the Minister said no before the budget was announced, and I think that's a very interesting point, a point that we will be bringing to the Minister. We are bringing a motion to the Assembly Chamber around junior doctors' pay in 2 weeks' time, but one thing that does disappoint me and concern me is the fact that the Minister in the response does say that the door remains open to engage in dialogue on these issues, the contract negotiations. And I want to know a little bit more from your perspective on this kind of obsession with the contract negotiations and completing those, and also the obsession with this wait until England and Wales have settled whenever we are a devolved nation, but also Scotland has seen theirs, I think it was 12.5 this year. So I just wanted to see from your perspective, you know, any insight as to those elements from the department's side.
No problem. I'll take some of that question and then I'll ask David to speak about the England and Wales carryover. Is that okay? First of all, I hope your son's okay.
Oh yes, he is.
Yeah. I'm glad you got good care. Yeah. Regarding the obsession with the contract, so the way our contract essentially works, so the way our pay works is we have our base pay and then we have a pay banding, which it covers additional, it's an uplift, a percentage uplift of your base salary, essentially for if you work more than 40 hours a week, which most of us do. If you work more than 48 hours a week, it's a little bit higher as well. It also covers whether or not you're doing lots of out of hours, the percentage of your out of hours, evenings, weekends, night shifts, that sort of thing. So when we're under the impression that the department want to move away from that system of pay, there's incremental pay rises on a yearly basis. Just from your time served, you get extra take-home pay.
On your base?
From your base, yeah. Your uplift is a percentage of your base salary, so for each year it's multiplied. There is difficulty with administration of that pay banding structure, so it's quite administratively heavy within our within our contract. It tells us that we have to undergo monitoring twice a year. It requires a lot of input from administrators. We have to fill in all the hours we worked, whether or not we had breaks, whether we finished late, why did we finish late, why did we not take our breaks. It's very heavy administratively, and I think that there's a bit of pressure maybe from the trusts to help do something that kind of removes that. From what we understand from the letters from the Minister, because that has been to date our only communication with the Minister has been through his letters, to date we understand that the Minister wants to move away from that, and we get the feeling that it's the pay banding issue that is actually the issue with the contract. Okay. And I think towards England have a different pay structure, and I think that they want to move a little bit more towards that, where an increase in base salary and a reduction in the uplifts. Regarding the pay that comes through England, or if England settle a deal, I'll let David speak on that.
Yeah, thank you. I suppose just to preface, we, Northern Ireland Consultants Committee, went into official pay dispute in September 23, and we have been working towards opening our ballot, but continuing to meet in good faith. I wouldn't say negotiation, because there hasn't been any negotiation, but when we were meeting in good faith and talking, the first barrier was there is no assembly, and as a devolved administration, health is devolved, and therefore we can't make any decisions until our health minister is back. And then when we met in February, we were told the minister's back, but we can't make any decisions until England have settled their deal. To which I went,
Can't? They're saying can't?
Can't. We had to wait until England settled their deal. I did ask, but I thought health was devolved, and it was flat out, no, we have to wait and see what happens so that we know what envelope we're negotiating within.
Can I just ask, I'm not sorry, David, for interrupting, is that, have they indicated that there's a potential bar no consequential then, have they said that?
That's a very good question, and one I was going to ask yourselves.
Okay.
Because England,
information as we
English consultants have went on strike a number of times throughout 2023. There was a pay offer put to English consultants, negotiated in December 23, put out in January, that was rejected. It went back and it was improved, and it was accepted in March, it was put out for referendum in March and accepted in April 24. That pay uplift it's not a contractual change for consultants, and there's a number of items within it, one of which is changing the consultant pay scale, which is a 19 point with 9 uplifts pay scale currently. So the Northern Ireland one is very tiered. There was a desire to move that to a 4-point scale over a 14-year time period. They got most of the way. It's a 5-point scale. They intend to move the 5th to a 4th point at some point in the future. But there was additional investment that was approximately 4.95% plus an additional £80 million of new money. Now the 4.95% was made up of dissolving clinical excellence awards on the lower award system in England and putting that funding into base pay, plus 3.45% of new money, which we have been led to believe will have a Barnett consequential attached to it. But we have not seen that in writing. We have not had confirmation of that, and we have asked repeatedly from the department if that would be the case.
Even if there was, it doesn't mean it will go to health. It'll go into the Department of Finance, and then it'll be filtered down to all of the other departments. So we will be following up, because I think these are quite serious issues. You said that you've been discussing with the Minister through letters, but we have correspondence that the Minister says that he's met the 3 chairs. It says that
March, wasn't it?
he has met.
Well, 3 of us met with the Department of Health officials in February.
Okay.
That's the only face-to-face meeting certainly that I've had, and nothing with the Minister.
He walked past us while we were sitting, but he wasn't in the room when we met.
Okay. He also said he had a meeting on the 26th of March. Did that happen?
That was the meeting that I had with Department of Health officials.
It was the officials.
Yes.
Yeah. And I know, understand the Minister's busy. Like, the Minister is busy, of course, but my understanding is before the first strike, this was the first of its kind for junior doctors, so something that is quite significant. It's also going to be a strike on the day that Encompass goes live, or Epic, on the Belfast Trust, and I do understand the reason behind that, for maximum effect, but hopefully we can follow in this, see some changes and really put pressure on. And I just want, my last question before we move on is just to reiterate that you do not think that you will achieve or get full pay restoration in 1 year. Just like, and you have never led anyone to believe that that's what you're negotiating for or asking it at any stage.
Yeah, despite what appears on newsreels, no one has ever asked for that number.
Okay. I think that's fair enough. Thank you. Just I checked it did say officials, didn't say the minister met.
Oh, it said
so just because
officials.
I thought that too. Linda.
Thank you, Chair, and thank you for the presentation. It is concerning to hear, I mean, others have already alluded to it, that the Minister is just saying a flat no, and particularly given that before there was even a budget allocation that you've already been given that response. That's really concerning to hear that. Excuse me, I have a couple of questions. Just firstly, has the Minister spent any time with junior doctors actually on the wards, getting an understanding and an idea of, I suppose, for want of a better term, a day in the life? Because no matter how much you talk to people and tell people what you are going through in your day, there is no way anybody can begin to imagine actually how difficult it is on the ground unless you actually see it. And I have seen it, and it's indescribable, and that's why I know that you couldn't understand it unless you actually went and seen it firsthand. And I don't mean 5 minutes in and out with the cameras. I mean actually going in and seeing it without any cameras to get a proper understanding, because obviously you're very limited to what you can do whenever there's media or cameras around, in terms of letting people be exposed to that, the patients themselves in particular. So I think that's my first point. The second point is, you've outlined there the issue around not getting breaks, not even a toilet break, never mind a lunch break. I'm really concerned about that, because what happens then in circumstances, because we all know what doctors have to deal with on a daily basis. Anybody that doesn't know that really is blind to what you have to do. But very often it's given extremely difficult news to families. Sometimes families that you've worked with and had dealings with over a long period of time, and you've, built relationships with, whether intentionally or not. So what happens there in terms of I don't even know what the right term here is, but decompression around just getting a wee bit of mental well-being time to process that yourselves? I'm assuming that just doesn't happen. And the final point then is, I mean, I think it's interesting that you've noted that despite the headlines, you're not looking for full pay restoration within 1 year. I think that the headlines over the strike period will be, we know what they'll be. They'll be about the impact on people on those days that you're striking, and forget about the other 363 days of the year when you're not striking and your inability to actually deliver. And you've just outlined that, I think, very well, in terms of the fact that, when it comes to surgery, that there are occasions in which by the time people are having that surgery, it is too late. And again, I'm sure that's devastating for any surgeon that is going in the hope that they're going to save somebody's loved one. So I suppose just those are more points, but I think there's some of them that maybe would like some commentary on. Thank you, Chair.
Yes, again, we understand that there's, with strike dates, there will be impact on patients. We will have to downturn services. But as I said, hopefully the events and the strike will actually help us achieve our aims, help us get more doctors to stay in Northern Ireland, to attract more people to come and work here. Therefore, we can expand our services, work on waiting lists, get them down and properly staff the place. So, as we said, as David had mentioned, hopefully one thing that we fix, if we fix pay, all of the other things we can work on after, but pay is the biggest thing that's driving people away, and it's something that can't be ignored. Maybe invite Leanne to talk about the other comment that you made about breaks and rest.
Yes, thank you for the question, and I agreed with your comment about the minimum staffing levels on strike days. We would quite like that on every day. And I've been a doctor for almost 30 years, and I've worked on the bad old days when it was literally some of the docs came in on a Friday and didn't go home until a Monday morning. That wasn't the contract I was on, but you were 24-hour shifts. I do remember 5 of us covering the surgical floor, and 3 of us somebody had been off on a holiday. There's 3 of us available, and we all felt unwell. And literally, we took each other's temperature to see who was covering the night shift. And mine was 38.5, and I got to go home. The person who was 37.5 got to stay, and I did his night the next night. And I really hoped that those days had gone, but I don't think they have. And I think the pressures that we're trying to prop up the failing system, and we can't do it by ourselves anymore. And you're working. I think the fear for doctors are that, you know, if something goes wrong, people want to ask questions, but that case is going to be looked at in isolation and not looked at in the context of what is going on around you, and that you have 30, ICU that I work in has 30 beds, so you have 28 patients. Most, I think, were staffed for 28 and up to 30, but you know, you're trying to look after those all of those patients and give them the care that you want. And sometimes, you don't get to take a coffee break, or you don't get to go to the toilet till you kind of realise that it's been quite some time. But from the point of view of breaking bad news, I think that was one of the questions that you asked on how that impacts on staff, and that's obviously something that we're very familiar with in ICU, because we're meeting people at crisis point. We look after people with head injuries, spinal cord injuries, after surgeries, pneumonias, everything apart from cardiac surgery and children in the Royal. So we do a lot of bad news, and we do make a point of giving the bleep to somebody else and making sure that we're in a quiet room and looking after the family as best we can, and making sure that they have adequate support. We look after ourselves to a certain extent. We prop each other up. We debrief ourselves. There were wobble rooms created during COVID where people could go and take 5 minutes. And certainly ours is 2 floors below us, so it can be hard to get to. But I think from the point of view of the services that are available for mental health and wellbeing of medical staff, particularly in England and Wales, the medical practitioner service is an invaluable service that they can, if people, sometimes doctors don't want to seek help from other doctors that they know and that they work with, and that system allowed doctors to reach out and receive, not anonymous, but treatment outside of their own hospital, and that's something that we don't have access to here. But I don't know if that goes part way to answering your question.
Yeah, it does. I mean, I just think it's concerning. If you're not getting breaks, I don't know how you could possibly deal with some of the extremely difficult issues that you have to deal with in everyday work. I mean, most of us be glad to see our breaks, and some days you don't get them, but we're not doing the work that you're doing. So it's not the same, you know, and I just think
the NHS would crash without its coffee.
Okay, Colin.
Yeah, thank you, Chair. Look, thank you for the presentation. I wish by telling us that we had some sort of solution for you, but invariably I don't think we're going to have. I think we'll write to a minister who'll say he doesn't have enough money, and then he'll go to an executive who say they don't have enough money, who regrettably are going to send it to the Tories, who will tell us that they've got no money, and it just makes you wonder at what point that cycle has to break. And I was going to ask you a question on the back of the question that I'd asked the GP, the British Medical Association GPs, when they said how close are we to primary care collapsing, and they said about 12 to 18 months. And I was going to ask you a similar question about just with the diminishing numbers and not replenishing the staff and not being able to get the work done, how close we are to the collapse of the service. But you know, you don't need to. You've told us that people are dying because they're on waiting lists because they're not getting seen quick enough. And if we've got a health service that's actually killing people because it's not treating them, then it's not working. And I just hope that we can get a message through to the Minister, Executive and Tories and whoever to say that our health system has collapsed, and please can they fix it. So I don't even think you need to comment on that. It's just to back up what you've said there. So thank you, Chair.
Thank you. Danny.
Thank you, Chair.
Thank you very much for all your presentations. Obviously, to get to be a doctor, people invest years and years of their lives, study very hard through university, and hope for a career that's going to, be rewarding and that they can help people, and they should be rewarded for the effort that they put into it. So it really is hard to hear that people who have done that are now walking away from the careers in medicine or walking away from Northern Ireland when they want to live here. I spoke to many of your colleagues on the picket lines, and they were heartbroken. It was a last resort, an absolute last resort for them. They didn't want to leave, but they simply couldn't. They couldn't stay here. It just wasn't doable. And I think what you said, just about that we have no choice but to act here. Inaction is not a choice. The health service is hemorrhaging staff, and it isn't just medical, it's nursing and it's social workers, and it's right across the board here. So we hear alarm bells all the time here, and if we don't have a workforce, we don't have a service. It is as simple as that. It's empty buildings, which is very, very concerning, because we all rely on the health service and we all need it. I just wanted to pick up on one thing that Dr. Farron said there. Mm-hmm. You said you were talking to registrars and you went round them all.
I was talking to consultants, in a number of trusts. I went round the Royal Victoria and Antrim Hospital, where I'm based, and spoke to 30-40 consultants in each place. So I was chatting to consultants on both sites. When I heard it the first time, I decided to ask actively about it, and literally everyone was saying, no, our registrars aren't interested in staying here. They're looking abroad, they're looking to the Republic of Ireland, they're looking to England, Scotland and Wales, because they see the prospects of it being better. I mean, to try and put some stuff into sort of figures, in Northern Ireland, on the last published waiting list stats, there were 428,000 people waiting on a first outpatient appointment. Over 212,000 of those were waiting over a year. That's an 81% increase in 3 years. That's not all the pandemic. That is from chronic underfunding. There's 115,000 people waiting on elective admission. And when you look at the number of doctors that have been employed, and one of the stats that was trotted out, was looking at the numbers have rapidly risen. They used an 8-year time window for that. If you look at the last 3 years, a total of 10.4 whole-time equivalents have been employed. In 3 years, 10.4 doctors. It's simply not sustainable. And you'd alluded to 12 to 18 months for general practice to collapse. I would argue that the health service is on the brink of collapse. I don't know 12 to 18 months is the correct prognosis. We are consistently seeing hospitals running at 120% bed occupancy. People are sitting on trolleys in the corner, in the corridor, where they could reach out their hand and touch the toes of the patient next to them. That is not a health service. That is triage medicine. That is battlefield medicine. It should not be like that. Mm-hmm.
And so certainly we're on the brink of collapse, effectively. We're staring over the cliff. And what you're saying about those registrars, those are our future consultants who are not going to be consultants?
Well, they'll be consultants, but not in Northern Ireland. They won't be joining our teams. They won't. The time and training and relationships that we have built with them will not translate to a colleague on a rota providing the service. It will be somebody else or a gap.
It's a massive, massive loss.
Yeah.
Thank you very much for
Alan Chambers.
Thanks, Chair. Dr. Farron, you referred to the registrars that Danny mentioned are talking to their consultants and saying, no, I'm not interested in staying. And you quoted better pay, better conditions, and they can get more opportunities to practice their skills. If they did get a decent pay settlement, on the heels of that, would they cancel their interviews in Dublin, Dundalk and Cork, or would they still go? You're quoting better conditions, so we can't change that overnight. We can, at a stroke of a pen, change their pay grade. But the other things, I was in hospital as an inpatient and was cared for by junior doctors and had interrogated them about their future, and I asked one young man who was just about to qualify what speciality had he his mind set on, and he said, no, I'm getting on a plane, first plane out of here as soon as I qualify. I'm going to Australia. And I said, why? Now he came back to front. He didn't start with pay or conditions. He started from climate, better life work balance. All the reasons why all sorts of people go to Australia and New Zealand, better, just better climate, better quality of life. The only little bit of hope in what he said was that he thought in the future he might come back. But I'm just wondering what can we do to induce, if it's not pay, is not the number one priority of young doctors, it's all those other issues. How do we, we can't quote the Northern Ireland climate to hold on to them, so we're having a lot going for us in that respect. Yeah. But, is it more than pay that those people are going for interviews down in the south of Ireland?
It is more than pay, but a key component is pay. And I'm not for a minute saying that every doctor who's planning on leaving Northern Ireland is leaving for the sole reason that they're getting paid more elsewhere. But we will not improve the other things until we attract more people here. So when we have gaps on rotas, doctors who are overstretched, overworked, covering and firefighting on a permanent daily basis, until those rotas that they work on and the teams that they work on are properly resourced, the actual work-life balance argument will never be fixed. So I'll give an example. We talked about working with outbreaks. I'm a medical microbiologist. I'm an infection control doctor. The last 4 years have been pretty busy. When COVID hit, I worked 57 days in a row without a break. 2 of those weeks were annual leave weeks where I was expected to, well, not expected, but I came in to help. I came in to chair meetings to try and keep our staff safe, to try and get protocols in place around testing right at the very beginning. We were promised at the end of that period of time we would have a downturn, we would have a period of rest. We didn't. We got asked for our elective activity to be upturned. We had to change things on the tip of a pin. Friday at 6 o'clock used to be the worst time if you weren't on call the weekend in my job, because you got the new set of guidance out. And all of a sudden, when I wasn't working at 6 o'clock, instead of sitting with my kids, I was on a computer trying to get guidance out to our doctors sitting on the ground or working on the ground with the people in ED to make sure that they weren't reading the guidance in England or reading the guidance on the internet and looking at our trust guidance and going, hang on, these two aren't right, which one do I do? Because that causes confusion, that causes fear, that causes accidents. So all of those sort of things all play in. We know, I don't think what we're asking for in Northern Ireland, it would be lovely if you matched the Republic of Ireland's salary scales, because I would immediately more than double my salary. I would have access to a £12,000 a year study budget instead of one that hasn't got a number attached to it. But, you know, to develop my professional skills is very, very challenging in a very resource-restricted environment. I don't think that's going to change. There will be people who will make the decision for purely financial reasons. There will be people who make decisions for family reasons. There will be people who make decisions because they want a better work-life balance. But as I said, we cannot fix the work-life balance bit until you're not having to work your own job plus part of somebody else's. I've been a consultant for nearly 12 years. At no point during that time have I worked one whole-time equivalent post. I'm currently routinely doing 25% overtime. At most I was doing 35% overtime. At least I was doing 15% overtime.
The pay really can be fixed at a stroke of a pen if somebody has the will to do it. But all those other things are long-term. They're not going to happen overnight. And, you know, will people cancel those interviews if there's at least light at the end of the tunnel that you know, that things are going to improve? Will that be enough to retain them?
I think some will. We know that to apply to do medicine in another country, you have to apply to the GMC for what's called a Certificate of Good Standing. There's been a record number of requests for Certificates of Good Standing in the 23 year, but a significant proportion, so I think the number is around 900, and about 650 of those are still registered with the GMC. So that's people showing a willingness that they could come back. The other way of looking at it is that the GMC run from August to August in terms of their fees. So it could just be that we haven't reached the point in time that they'll just put a line through it and say, I don't need it for this year. But I would like to think if we fixed pay, we would start to see people coming in, because it makes it a less challenging. You know, I myself, I'll be completely frank and honest, I myself was applying for jobs in Dublin up until December of this year. I changed my plans because of family reasons. But actually, to me, a 2-hour commute from my house, I live in Lisburn, I could have jumped on the train. I would have doubled my salary. My wife would have been able to cut hours and look after our kids a little bit better. It would have made financial sense for me. A slight amount more here in my salary would actually have made that 2-hour commute probably work against that. So there'll be multiple factors that people will pull in, but pay is a critical one.
Dr. Griffin, if I could maybe just a quick question, Chair, on where you say the Minister had give you a flat no. What did he give you a flat no to? What were you asking for on the table that he gave you a flat no on?
We had asked if we were to engage in the contract reform that the Minister had suggested, if we were in the process of engaging with that, could we come to the table and negotiate a percentage uplift above the DDRB recommendation for this year? We hadn't asked for a figure, we hadn't said X percent, we had said, can we come and have the opportunity to negotiate that while we are working on our contract? And we were told no.
Yeah, in another life, in business, if I'm negotiating with somebody and I go to them and I put my demands on the table and they say no, I don't walk away. I say, well, hold on a wee minute, what's your bottom line? Let's talk. But, so saying no goes two ways. If you walked away from the negotiations just on the strength of that, did you not feel that maybe you could have, strong-armed them to actually sit down and talk rather than just accept a blank no from him?
So we also wrote the Minister a letter to say that we had received his no and we urged him to reconsider that, and we have yet to receive a reply from that, and that was about a fortnight ago. So it really is a two-way street, Mr. Chambers. I think that any kind of negotiation, it has to be in good faith. Yep. And actually to be told no, again, if I'd come to the table and said I want 15%, again, completely just made that up. If I come to the table and said that, I said no, let's talk about a lower figure. There's a negotiation to be had, and we're ready for that negotiation. But to say no is the end of the discussion. Mm-hmm. And then to send a letter and to ignore and to not send a response is also the end of the discussion. And I know the Minister sat here last week and said that his door was open, but our experience is that the gate has been locked. We can't get to the door.
Okay, thank you.
Yeah, no, thank you. I think for me it's very obvious that the central issue here is pay. The figures that you've presented us with have made that very, very clear. And I think that if we can get some progress on that, that will help to resolve some of those other problems. Certainly from my engagement with yourselves and one of your colleagues, and it's something that stuck in my head, had told me about how she has her house up for sale. Her and her husband and her child are currently in the process of moving. That's moving their family, that's moving away from your support. Particularly if you have a young family. So if that doesn't speak volumes to people, I don't know what will. Because certainly I know as having a young family that it suits me better to work close to home, because I know I have a support network around, I have my friends, to completely move your life somewhere else, because you're not getting valued for the work that you do. You're not getting a pay that reflects the rising cost of living, that reflects the real challenges of the job you're facing. David, what you've outlined there, even during the COVID period, I think is a real insight into what we're talking about here. And Linda talked about someone going on the ward and seeing that in real time. I think you've outlined that very, very clearly about what sacrifices you and your colleagues are making. So that's the message we need to get out of here today. I don't think the asks are unreasonable, but you're willing to talk and to work with what the financial envelope is within the remit, but you can't do that if people are putting up a barrier. So thank you all very much for your time, and hopefully we will see some progress. Certainly as a committee we work to try and support that to move forward. Okay.
Thank you very much. Thank you.
Okay, members, thank you for that. Just coming out of that, there's a couple of things I would like to request that we write to the Minister on. I think firstly we need an update on this pay issue. The fact that the doctors have been told no is very, very disappointing. So I would like to maybe get an update on where the Minister sees this going, what the next steps are. Johnny?
Do we even go further and ask the Minister to meet with them as a matter of urgency? They've said they've had no communication now. Meeting with officials, I think was it March, February? Yeah. So, obviously long overdue.
Yeah. No, absolutely. I have no issue with that if others don't as well. The other thing that, two other things I wanted to maybe ask for was an update on the Clinical Excellence Awards and where that's at, because they've said there that had disappeared, and I think that's an important factor.
Cut them to save money. I understand difficult choices have to be made.
We need an understanding of that and what the impact is of them cutting that. as well. And the other one is, if possible, we could ask the Minister of the Department, are they expecting a Barnett consequential? And will that change where we're at the minute? I think, are they fair enough, those questions?
Chair.
Yes, Linda.
Sorry, just on the Barnett consequential issue, we should obviously ask if they're expecting Barnett consequential, but have they put a bid in for that? If it is expected, has the Health Department actually actively put a bid into the Finance Department on what they would want that money for specifically, and that they would be expecting to get it?
Yeah.
Particularly if it's around pay and consultants' pay.
Yeah.
Can we also try and sort out this disagreement that there is between the department and various bodies about vacancy rates? It seems to be that the vacancy is only counted if they're actively recruiting it, not if there's an actual vacancy, which just seems ludicrous, because it's like a massive attempt to try and hide that there are massive gaps. Because, and even is there a way, does the department track those that leave jobs and leave this place to go to elsewhere? Because there used to be a sense that we trained people and they went away, like that was something that was their fault. But if our pay is the lowest ever anywhere, well, all we're going to do is be training people to send them off to other places to actually go. And I don't know if we can ask the universities, do they keep a record of people that graduate, where do they go to? But it just seems that if we're not going to pay people to go elsewhere, and we're spending money out of another department to train people to be doctors, and then because of the conditions that they're left with, it just might add to the argument that we need to do something to try and keep them.
Yeah, and we did. I think I raised this with RCN actually the week that they were in as well, because we were saying, had they any sense of the people who have trained here but actually have left? And also the Southern Government are funding places for medical students here, which is essentially feeding into this discussion around where they're going to go after that. So yeah, if we can, I don't know whether they do, but if we can ask if there's any sort of track on that as well. Okay, members, we'll move on to the next briefing. I'm going to have to keep this fairly tight. So we have the briefing on the Westminster Victims and Prisoners Bill, the Infected Blood Scheme. We have a number of papers in relation to this. So at page 28 is the department's briefing paper. Page 37 is ministerial correspondence on the issue. Page 49 is an inquiry first interim report. Page 66 is the second inquiry interim report. And page 166 is correspondence from Haemophilia NI, who some of us did meet at the strategic planning day as well. So in attendance today we have Leslie Heaney, who's head of the Infected Blood Inquiry Team, and Liz Redmond, Director of Population Health. You're both very welcome. Apologies, we're a wee bit delayed today, so we appreciate you waiting. So thank you. If you want to open, and then I'll open up to questions.
Thank you very much. Thanks for asking us to attend today. So my colleague Leslie and I are here to brief you on the Victims and Prisoners Bill, which is UK-wide legislation made at Westminster to establish a UK-wide infected blood compensation scheme. I hope you've seen our written paper that we provided to the committee on the 30th of April. There have been a few developments since then. And my intention is to provide you with, in these opening remarks, with a little bit of an update and overview on what's happened since then. Minister Swan wrote to your committee on the 21st of March to advise that the UK government planned to bring forward amendments to the Victims and Prisoners Bill in order to establish a UK-wide compensation scheme, and this is for people infected and or affected by contaminated blood. The committee was advised that the bill in its original form only applied to England and Wales, and that in order to establish a UK-wide compensation scheme, the relevant amendment would need to be extended to include Northern Ireland and Scotland. Legislative consent would also need to be requested from all the devolved administrations to ensure that infected blood compensation scheme set up under this legislation is UK-wide. The written briefing paper, which we sent to your committee in April, set out the rationale for a UK-wide compensation scheme. This can be summarised as follows. The first point being that the chair of the Infected Blood Inquiry, Sir Brian Langstaff, recommended in his second interim report that a UK-wide compensation scheme should be set up, and that it should have central organisation, concentrating resource and expertise. The second point I think there is that the infected blood tragedies occurred between 1970 and 1971, which was prior to the devolution of legislative and executive powers to Northern Ireland, Scotland or Wales. The third point is that the final submissions to the infected blood inquiry from Northern Ireland Corps participants in the infected blood community here supported a single UK scheme to ensure that all those affected across the UK are treated fairly. There is a fear, I think, that further political instability here could put those who are affected in Northern Ireland at a disadvantage if we were not part of a UK-wide scheme. Another point there about a UK-wide scheme would be it would mitigate against the risk of further disparities in financial redress across the UK administrations. Additionally, Northern Ireland does not have the financial resource to fund a compensation scheme of the order of magnitude recommended by Sir Brian Langstaff. Estimates suggest that a compensation scheme, as proposed, will run into billions of pounds. Also, given our small size and population, Northern Ireland simply does not have the clinical or legal expertise to establish the expert panels that are proposed by Sir Brian. So that's really the rationale that we see for Northern Ireland's inclusion. The briefing paper set out for you also the risks of not including Northern Ireland in the bill. I think the first being the potential cost, administrative and financial, associated with setting up a separate Northern Ireland compensation scheme. There would be a diversion of policy resource in our department and resources of the Assembly, and a requirement to add to the legislative timetable here. Also, to legislate for a specific NI scheme could create a risk that funding may have to be found from within the existing Northern Ireland block grant, which could impact on public services, as something would have to be stopped to fund that compensation. Not taking the opportunity to be part of a Treasury-funded UK scheme would also go against the recommendation of Sir Brian Langstaff, and that would be considered controversial. Even if the budget and expertise were available to set up a Northern Ireland compensation scheme, this could potentially take longer and risk for future divergence. And as I've said already, the preference of Northern Ireland representative groups is for a central UK compensation body to oversee a compensation scheme. So turning now to the legislative process in Westminster and the legislative consent process here. On the 17th of April, the UK government tabled its amendments to Part 3 of the Victims and Prisoners Bill in order to provide the legal framework required to respond to the infected blood inquiry recommendations on compensation. The amendment requires the Secretary of State or Minister of Cabinet Office to establish an arm's length body to be named the Infected Blood Compensation Authority, or IBCA, on the day of royal assent for the bill to administer an infected blood compensation scheme. Subject to consent from the devolved administrations, this IBCA will operate on a UK-wide basis to ensure parity and consistency. The amendment to the bill also places a duty on the UK government to establish a statutory infected blood compensation scheme for those infected and or affected by contaminated blood by way of subsequent regulation. The amendment enables the Secretary of State or Minister of Cabinet Office to specify bodies which will have a duty to cooperate with the IBCA. The regulations will not be able to specify a Northern Ireland body or person, however, without the consent of the Northern Ireland Department of Health. The amendment to the bill also provides the power for the Secretary of State or Minister of the Cabinet Office to make one or more transfer schemes for the purposes of transferring rights and liabilities to the IBCA to carry out its functions. It will not be possible for a transfer scheme to be made in respect of the Department of Health or the Business Services Organisation, that's BSO, unless the department consents to that. The UK Government amendment to Part 5 of the bill extends the territorial scope of Part 3 of the bill, that is the part relating to the infected blood compensation, to the whole of the UK. So Part 3 and Part 5 are both relevant. In addition, the amendment will require the UK government to make further interim compensation payments of £100,000 to personal representatives, that is the estates of qualifying infected deceased persons. And I'll talk a little bit more about that in a minute. So the bill was debated in the House of Lords on the 30th of April, and most of the UK government amendments were agreed. The UK government also accepted a Labour amendment to deliver the regulations to establish the compensation scheme within 3 months of the bill receiving royal assent. So, in other words, the regulations to establish the scheme would need to be made within 3 months of the bill becoming law. However, the bill was not debated in totality on the 30th of April. Midway through consideration of Part 3, the further debate was adjourned until the 13th of May, and we've subsequently, very recently, only yesterday, been told that that debate has now been rescheduled for the Tuesday, the 21st of May. The amended clause in Part 5 of the bill, that's the bit which makes the provision to extend Part 3 to Northern Ireland, has therefore not yet been debated or agreed. I mentioned that provision is made through the amendment of Part 3 for further interim compensation payments. So this is in respect of estates of those who died before July 2022 who have not had a partner or spouse or estate already recognised through the previous interim payments made in October 2022. Now, this is not exactly in line with Recommendation 12 of the inquiry's second interim report, which was that an interim payment of £100,000 should be paid to recognise the deaths of people who have to date been unrecognised, and specifically this recommendation said payments should be made to bereaved parents, split equally if separated. Payments should be made to a bereaved child or children, including adopted children, split equally. And where someone infected has died and there's no bereaved partner, child or parent, payment should be made to a bereaved full sibling or siblings, split equally. So, given the sheer complexity of administering such a scheme, that is the scheme that was set out in that recommendation, and the length of time that would take, the UK government amendment requires instead that the interim compensation payments are made to personal representatives of qualified infected persons who are deceased. So the personal representative would be required to distribute the monies in accordance with the deceased person's will, or under the rules of intestacy where there's no will. The policy for these interim payments would be that only one payment could be made per deceased person. So if, following the inquiry's interim report in July 2022, a partner or spouse beneficiary has already received a payment of £100,000, or subsequently an estate of someone who passed away after July 2022 received a £100,000 payment, then there'll be no further interim payment in respect of the deceased person under this interim provision. So these interim payments as set out in the bill represent a solution that should see compensation paid relatively quickly to affected relatives named in the deceased's will or in intestacy rules. For those cases which do not meet the criteria set out in the bill, a claim can be made to the new infected blood compensation scheme when that's been established and it's operational. Turning now to the process of seeking legislative consent from the Northern Ireland Assembly, Minister Swan wrote to the Minister of the Cabinet Office, John Glend MP, on the 24th of April to confirm his intention to seek the consent of the Northern Ireland Assembly so that Part 3 of the bill extends to Northern Ireland by way of Part 5, as I've explained. Under Assembly Standing Order 42A, an LCM should be laid within 10 working days, I'm sure you're familiar with this, from the day the bill completes the stage in Parliament during which the amendment is made that affects Northern Ireland. The Scottish Parliament gave its consent to inclusion in the bill on the 30th of April following consideration by its Health and Delegated Powers Committees, and they have written to the Minister of the Cabinet Office to confirm that already. The matter has also been debated in the Welsh Parliament earlier this week on the 7th of May. Members voted and agreed the motion to consent to Part 3 of the bill. So Scotland and Wales have both now consented. So at the same time as Minister Swan wrote initially to your committee on the 21st of March, he also wrote to executive colleagues to seek their agreement in principle, setting out in detail the rationale for Northern Ireland's inclusion in the bill. A further executive paper will be shared for discussion at the executive meeting on the 23rd of May in 2 weeks. At that point, Minister will also write again to your committee to provide an update. Following this, a legislative consent memorandum will be sent to the Speaker requesting a legislative consent motion be debated. The UK Government is working to achieve royal assent for the bill before the summer recess. So I just wanted to finish with a few words on consultation, just to cover that point. The infected blood inquiry is obviously a UK inquiry sponsored by the Cabinet Office. The UK Government has accepted moral responsibility for the infected blood tragedies and is leading on the work to respond to the inquiry's recommendations for compensation. The decision to use this bill as a means to establish a compensation scheme came about as a result of an opposition amendment, in reply to which the UK Government tabled the amendment that we have been discussing that is currently in the House of Lords. Therefore, there has been no formal written consultation process around this. However, the Minister for the Cabinet Officer, John Glenn MP, has written to and subsequently met with key stakeholders in Northern Ireland about this, namely the Haemophilia Society, Haemophilia NI and families and friends of Haemophilia NI on the 3rd of May. Minister Swan also attended that meeting to offer his direct support to those in attendance. Minister Swan has also met with these representative groups a number of times since he first took office in January 2020, and recently, prior to the meeting with the Minister for the Cabinet Office, Minister Swan met with groups on the 14th of March to discuss the Victims and Prisoners Bill and a UK compensation scheme. The infected and affected community, including the main representative groups in Northern Ireland, provided evidence to the inquiry and were also consulted by Sir Robert Francis's compensation framework study, which informed the inquiry's recommendations on financial support. The UK Government amendment is based on recommendations from the Infected Blood Inquiry's second interim report. In conclusion, I think the inclusion of Northern Ireland in the Victims and Prisoners Bill will ensure that those in the infected and affected community here will have the opportunity to apply to a UK-wide compensation scheme along with those in other UK jurisdictions as recommended by the Chair of the Infected Blood Inquiry. So thank you again for inviting us to attend today, and we're very happy to take any questions, and of course we will be writing to you again within the next couple of weeks.
Thank you,
Okay.
Liz. And you've answered probably every question that I had ahead of the briefing, specifically around the £100,000 payments and who that would be made to and how that would be. We weren't sure if it was to one person and you've clarified a lot of that. You've also talked about the consultation, and I did want to ask I know you said that the British government have consulted with some of the groups here in the north, but has there been any consultation then or any engagement in the interim, I suppose, before the LCM is laid with the department and those groups? I know we have met with Nigel Hamilton from Haemophilia, and I know their AGM is coming up as well. But it's just to try and get a sense of that. And my only other question then is, you've outlined a bit of a time frame around the laying of the LCM in the Assembly. Do we have any projected date on when that is likely to come? I know you kind of talked about the executive meeting and that, so just to give us an idea. So that's all really from me.
Just take your second one first, and I might turn to Leslie on the first question, as she's very much in touch with the community here. So on the second point, we are just actually currently taking some advice on that, because we're unsure whether we can proceed with legislative consent on the basis of Part 3 being agreed, which is the substance, if you like, or whether we need to wait until Part 5 is also agreed, which is the part of the bill that extends the territorial extent of Part 3 around the compensation arrangements to Northern Ireland. So we're just taking advice on that now. However, we do need to go back to the executive, and we are timetabled in for the 23rd of May. So it's very likely to all happen at about that time. And so the LCM should be basically progressing just after that. That's our current estimation. We have already had a shift in time frames from the House of Lords, so we can't vouch for that and what's going to happen there. But we will proceed anyway if our legal advice is that we can without Part 5. So I'm afraid I can't be absolute, but we think it's about 2 weeks from now when it will start.
Okay,
yeah.
That's grand, thank you.
Okay, so Leslie, do you want to comment on the consultation?
Yep. So there's been, I think Liz has already covered most of it, but there's been no formal consultation in Northern Ireland because the Infected Blood Inquiry is UK-wide, sponsored by the Cabinet Office, and the UK government has accepted moral responsibility for the tragedies. As Liz already said, the Minister for the Cabinet Office is leading on engagement with our stakeholders and has met with our stakeholders on Friday the 3rd of May. At which Minister Swan was in attendance. Minister Swan did meet with those same groups himself earlier, shortly after coming back into post. He met them on the 14th of March to discuss the Victims and Prisoners Bill and the UK compensation scheme and the plans that the UK government has for that. And I think it's also important to bear in mind as well that the infected, what we call the infected and affected community, including those main groups that were mentioned, all provided evidence to the inquiry and were consulted during Sir Robert Francis's compensation framework study, which informed the inquiry's recommendations, and the UK government amendment is based on the inquiry's recommendations.
Okay, no, sorry, and you did say that about the Minister had met them, so apologies, I'd forgotten that as it was coming back. Danny?
Yeah, thank you for that. And obviously this has been a long-standing campaign here in Northern Ireland for many, many years, and sadly, as mentioned, some people have passed away during that campaign. Now, obviously, it is very important that that these people get the compensation that they are entitled to. You've mentioned the meeting that the Minister has had with the community. So can I take it from that the Minister is aware of the concerns that have been raised by the community, in particular the deviations from the recommendations? Now, some of them, particularly the removal of timescales, and there is a lot of uncertainty around this. So is there any movement between the Minister supporting the concerns that have been raised by members of the haemophilia community and the infected blood community about these deviations from the recommendations? Can you give us any clarity on that?
The Minister met with the groups in March, on the 14th of March, so that was actually a month before the UK government amendment was actually tabled in the House of Lords. So at that point, those deviations that you refer to, we wouldn't have been aware of those, and they wouldn't have been aware of those. But those are issues, excuse me, that they will have raised with John Glenn, the Minister for the Cabinet Office, when they met with him on Friday the 3rd. From what I can understand about the deviations, the issues around the chair and things like that, they're all matters for the Cabinet Office to do with the appointment of the chair to the Compensation Authority and those kind of things. So those are issues that would be for the Cabinet Office rather than devolved matters. So they haven't written to Minister Swan to raise those, presumably because the engagement has taken place with the MCO.
The Minister certainly is aware of the concerns raised by the community here in Northern Ireland about those deviations.
He will be aware because he was at that meeting.
Thank you.
Okay, I have no further questions from anyone, but thank you both. That's definitely been very, very useful, and it's given us the update as to where things are at, so thanks. I'm sure we'll see you again very soon. So, all the best.
Thank you.
Members, just to advise then that we will be briefed, or we will consider the LCM then once it has been laid, so we'll wait for that. Hopefully it won't take too long. Members, item number 8 then is correspondence. If I could refer you to tab 8.1 in your pack, between pages 169 and 198 then. Just a couple of things I wanted to draw your attention to. The first one is the Minister's reply to the committee regarding ambulance handover times, which is at page 170. That came out of a letter from Chris Hazard MP. And just on that, this afternoon I met with the ACE first responders who have been set up just over a year in the Aher, Clogher and Esker area. I was going to say that 5 Mile Town. But I mean, a fantastic organisation, and I think we all are very aware of the important role of community first responders. But what is really concerning is that over a year on, they have been unable to operate because they can't get access, they can't get the training that's required, which is essentially impacting on their ability to save lives. Particularly when we see the really concerning ambulance response times for Category 1 calls, Category 2, all of those. When we had the chief executives of the Trust and NIAS in February, I had raised this issue with the chief executive of NIAS, as it had been brought to my attention from community first responders in another part of the north, and I was given assurances that training was coming up. So I'm now hearing that the person who was dealing with that in terms of training and recruitment and all of that has now left the post, and since then there's been a radio silence in terms of when training is for this group. They were told initially it was coming September last year, so it's very worrying. Plus we could lose really, really skilled volunteers who could provide very, very crucial interventions for particularly rural communities and those areas maybe where there's going to be struggles getting an ambulance there when it's needed, particularly in the current context as well. So I would like to ask members for agreement to write the Minister for an urgent update on the training for community first responders, because we need to ensure that that's happening ASAP, particularly if in the role that it can play in supporting ambulance service and improving patient outcomes, I suppose, is the...
Sure, whatever happened to the pilot scheme maybe 3 or 4 years ago? I think it was maybe in the Glens of Antrim, where the fire service were, and that seemed to be getting launched, and then it just disappeared off the radar. So
yeah.
Just wondering what update on that?
Yeah, well, I think, and that's actually something that came up in the discussion this morning around the role the fire service may be able to play as well in supporting with training. Is there any scope to, if they're having difficulties training?
I think it was something to do with insurance or something, that the fire service were concerned about, administering first aid and maybe negligence and that sort of
I'm
stuff.
maybe coming at it from a different angle, Alan. What I'm saying is that they may have people within their team who could assist with training the first responders. So if we could maybe add that on, say, is there any exploration around, instead of it, if NIAS are having capacity issues in delivering the training, is there scope to look at other areas that may be able to assist? Like, for example, one of the guys I met this morning is a cardiac nurse who probably could deliver the training, but as you mentioned, maybe for insurance reasons and other reasons, isn't able to do that. So I just think it's a really vital service. It's cost very little. I mean, these organisations are fundraising themselves to get the equipment and all of the things that they need, and they're giving up their free time to save lives essentially, and to prevent people from ending up in a worse condition than they would. So I think it's a very important one. So are members happy enough to ask for that? And just then, if we could also agree to forward the response to Chris Hazard, who sent the original letter in terms of handover times. Is there any other actions on the remaining correspondence as listed that anyone would like to raise?
Certainly the invite from ADD&I, or the request for a meeting from ADD&I, certainly given the lack of a commissioned service in Northern Ireland, I think is referred to by the petition that's presented there as well. I think it'd be very important to meet, and certainly I've met with these people previously, and it is a huge lack of a service for a huge number of people across Northern Ireland. So
yeah, no, absolutely. Well, if we can look at to see if there's potential, whether it's in a statutory committee meeting or if it's an informal session with the committee, I think it is important, given that it is a growing issue. I think we're hearing more and more about it. So are members then happy to note the actions on the remaining correspondence as listed in the memo. Yep. Thank you. Item number 9 then is the forward work programme, which is at page 200 and 202 of your pack. The next informal meeting with the department is scheduled for next Tuesday, the 14th of May, in room 21, and we will have officials present to talk to members about the strategic plan and performance group, the SPPPG. The meeting will start at 1 p.m. and lunch will be provided. An invite will be issued, but if I can ask members if they can, or SVP, because we found last week there was only 2 of us in attendance, and it was a really, really good session on care pathways. I understand it's a very, very difficult time, but if we can give an indication, because there's a lot of work goes into organising those meetings. I know I have had to give an apology for this week, but just so that staff can organise to suit. Are members content then to note the briefings as set out in the forward work programme? Any other business anyone wish to raise? No. Okay, and the next meeting will be next Thursday, 16th of May at 2 p.m. in room 29. So thank you very much, everyone. Safe home.
Thank you. Committee room 29. Sound.